shorter GP2B3A inhibitor infusions with the use of radial approach provides the greatest benefit for our patients. GP2B3A inhibitors have the greatest role in treatment of high-risk patients and those who are undergoing a high-risk PCI with angiographic features where you see some visible thrombus and high-risk anatomy who have low risk of bleeding. So these are the patients who benefit the most. Currently, the ACCHA gives a class 2A recommendation for use of GP2B3A inhibitors at the time of primary PCI, and intracoronary abciximab is a class 2B indication. So definitely GP2B3A inhibitors have been associated with reduced thrombotic events when you compare them with heparin or bivalirudin, but routine use, especially with prolonged infusion durations, is associated with severe bleeding complications, and also it increases the PCI cost. So provisional use, shortened use, use with radial approach, these are the strategies to use them. Also in certain scenarios like this, in a 28-year-old smoker who presented with evolved Androvol MI, this was a late presentation, he came beyond 24 hours. So he had an ostial LAD total occlusion. So we tried wiring, we did thrombosuction, couple of runs, then we gave intracoronary drugs, but we ended up with the same flow as before. And we left him at this stage and gave overnight GP2B3A inhibitor. And this was how it looked the next day. Plenty of thrombus in LAD, but flow was restored. So to conclude, increasing complexity of PCI in high-risk patients, parenteral antiplatelet agents definitely have an important therapeutic role. Parenteral agents obviate the limitations of the oral P2Y12 inhibitors, but they are associated with greater bleeding. Whether to use cangrelor or GP2B3A inhibitors, it's an unresolved issue. There are no trials to compare them. Whether GP2B3A inhibitors or cangrelor add significant clinical antithrombotic effects in a patient who is already on a strong P2Y12 inhibition is also not known. So most of the indications are all for treatment-naive patients who present for the first time. The major potential benefit of GP2B3A inhibitors over cangrelor is that it inhibits aggregation induced by all of the agonists. The downside, of course, is it has a slower offset and has a little bit of risk. Thank you.
I welcome Dr.
I
Cecil
thank
Mary.
Dr. Shilpa Jayaprakash Madam, Associate Professor, Jayadeva Institute of Medical Sciences for an excellent talk. I now invite Dr. Cecily Mary Magella Madam to deliver a talk on primary PCI, navigating the challenges.
Good morning, one and all. Respected chairpersons, distinguished senior colleagues, and my dear friends. The topic today is the burning topic, primary PCI, navigating the challenges. So how to optimize reperfusion in acute MI? The problem, a longer delay for presentation. The solution, large media education. The delay in transportation, logistical protocols has to be instituted. The delay for treatment in hospital, quality care, the very good in Tamil Nadu and all over India, the STEMI protocol of a hub and spoke model for early reperfusion. So the clot management in primary PCI, it's like fighting your enemy. It is a battlefield. Every primary PCI taken up is a real battlefield. Taking inspiration from the ancient wisdom of fighting a war, An interventionist should look first into the strength of the enemy, that is, assess the thrombus burden. This is to be followed by choosing the appropriate strategy to attack with aspiration or mechanical thrombectomy if necessary, to surround with pharmacological therapy, including oral and parenteral antiplatelet therapy, as well as intracoronary thrombolytic therapy. To avoid stenting strategies, including direct stenting and deferred stenting. To battle, when necessary, with stenting under a distal protection device, if necessary, especially in SPG graft occlusions, or stenting across a local obstructive thrombus. To flee and to move away from PCI and to go in for an optimal antithrombotic therapy and circulatory support when flow fails to be regained, especially in circulatory shocks. And the key remains to adopt not one strategy. Every patient is different, so we have to adopt different strategies selectively and appropriately in different scenarios, as rightly said by Dr. Rupa Salma ma'am. Yesterday the discussion was great. So we have to assess the thrombus burden. We have to look into thrombolysis in MI grading for thrombus burden, as well as the angiographic features indicative of a high thrombus burden. High thrombus grade has been shown to be a predictor of distal embolization in primary angioplasty. Notably, the total thrombotic occlusion given the highest grade 5, but the actual thrombus load in a totally occluded lesion is uncertain. So, in fact, after exclusion of patients with patient infarct-related artery, TIMI grade 5 became not to be regarded as an independent predictor of distal embolization. So how to go about this? We look into the thrombus grade, both angiographically and the TIMI grading. Thus, when there is a total thrombotic lesion is encountered, it is recommended to first establish the flow by guide wire or crossing of a passage of a non-inflated balloon. Thereafter, the thrombus grading has to be re-stratified and TIMI grade 1 to 4 with grade 1 to 3 indicating a small thrombus burden and grade 4 representing a large thrombus burden. So after establishing the flow, we have to re-stratify these patients. Large thrombus burden of grade 4 has been reported as a predictor of stent thrombosis and major advanced cardiac events at 2 years. So the proposed algorithm for thrombus management during primary PCI, we assess the scoring systems, then we go in for assess them, then if necessary aspiration thrombectomy in necessary cases, still we have a large thrombus burden, we go in for repeated suction as well as glycoprotein inhibitors, and if necessary, as madam said, IV cangrelor, or we also load them with drugs, and then we assess the flow and then plan accordingly. So what is the advantage of direct stenting in primary PCI? It minimizes manipulation of thrombus and to fix the thrombus behind the stent and to reduce distal embolization. But the major disadvantages are there. It underestimates the true vessel size, difficulty in passage of a stent through a tight or a small calcific nodule or a calcified vessel. There could be stent under expansion, late malapposition. The length of the stent could be even underestimated or overestimated. Without clear demonstrable benefit, the decision for direct stenting should primarily be based on the lesion anatomy. Although aspiration thrombectomy can facilitate direct stenting, it should not be performed solely for this purpose. Deferred stenting. So deferred stenting is, as a routine strategy, is not appropriate, but it is considered in presence of high residual thrombus burden after initial treatment with thrombectomy or pharmacological therapy, and when the patient is considered high risk for no or slow flow. The ideal deferral time is not well defined by clinical data, but many studies suggest that approximately, some studies suggest as 3 days and some studies suggest 5 days is reasonable, balancing the time required for more optimal thrombus resolution and avoiding excessive delays in completing the PCI. Noting the risk of abortion also during the waiting period, it is prudent to adopt deferred stage 2 flow, preferably 3 flow such. Moreover, it is recommended to put the patient in the waiting period with GP inhibitors and heparin unless contraindicated. So stenting across local obstructive thrombus. Flow remains TIMI 0 or 1 because of local obstruction by residual thrombi in the proximal or mid segment. Confirmation of the latter can be achieved by angiography using contrast injection through a dual lumen catheter placed in the distal vessel, which is being pulled back while contrast injection is maintained. In this scenario, stenting across the local thrombus to splint the thrombus may be helpful to maintain lumen patency and restore the flow. So this is a 37-year-old female with acute extensive antral MI within the time window with an ejection fraction of 36%. So this is, we know this is a completely occluded vessel, but there is no flow. So we can't wait in such a situation. We need to wire and establish the flow. Using all means, we have to establish the flow. But at least as madam said, if some flow is established and there is a residual thrombus, then we can put them on drugs. So each case has to be individualized. So when to flee, when to avoid a PCI in a setting, acute STEMI setting. There are cases that fail to achieve more than TIMI flow despite adopting various strategies for maintaining thrombus and no reflow. The incidence is around 1 to 2.5%. This may be because of the extensive thrombosis that could lead to microvascular dysfunction. So PCI needs to be adjourned. So the pharmacological and mechanical circulatory support has to be provided as indicated depending upon the hemodynamic parameters. This allows time for the thrombus to resolve, the microvascular function to recover. So sometimes in young patients, when there is a decision making, I will show you one of them. So there is a huge chunk of thrombus in the LAD. So such patients, the flow is established. We are able to see the distal flow. So in this, at such situations, we need not be very heroic. We can put them on drugs, optimal drugs, stabilize them, and take them whenever necessary after 3 to 5 days. That is the ideal period. So no reflow. So it is epicardial obstruction, yes or no. Whether it is a dissection, air embolism, a proximal thrombus, we have to go accordingly. And we have innumerable drugs. The dosage is given and complete the case, or else go in for the other strategies. So culprit only versus immediate multi-vessel PCI in patients with acute MI, especially complicated with advanced cardiogenic shock requiring a VA ECMO. So among these patients with acute MI, multivessel disease with cardiogenic shock and VA ECMO, before revascularization, immediate multivessel PCI was associated with lower incidences of 30-day mortality or renal replacement therapy at 12-month follow-up mortality compared with culprit-only PCI. This is one of the indications for multivessel PCI in the acute setting. So intracoronary imaging in ACS patients undergoing PCI. Increased use in intracoronary imaging from 1.4 to 13.5%. Less than 1 in 7 patients receiving intracoronary imaging. Use of intracoronary imaging associated with better outcomes, benefits mainly in left main stenting and osteoproximal or left main to LAD stenting with significantly lower MACE rates and mortality. The overall increased incidence of IVUS use, 5.6%. IVUS more than OCT in left main and multivessel PCI, especially with renal disease. OCT over IVUS in STEMI, previous PCI, instant restenosis. Both have better outcomes than no imaging in these specialized population. So the optimal strategy for a left main PCI, especially with a high thrombus burden in the left main, where it is associated with slow flow and no reflow. So the embolism to the LAD or circumflex would lead to MI and additional angioplasty. So for patients with cardiogenic shock undergoing primary PCI, which is frequent 26%, when the left main coronary artery is occluded with a heavy thrombus burden, deferred stent implantation can improve the perfusion and cut down time and contrast agent consumption. Deferred stent implantation as a strategy to reduce complications is probably better than immediate stenting in left main PCI with a large thrombus burden. Such thrombus, we can wait and watch and give the drugs and then take up. But here's another patient in our center with an acute, presenting with cardiogenic shock. The angio revealed a very tight left main. The patient could not be taken up for CABG. CABG was deferred. There is not much of thrombus here. But the patient with a tight left main, our option is it has to be individualized. We will go for a stenting. And this is the final result in a government hospital at Chennai. We are able to establish the immediate result and save the patient. And also, we should know to manage all the complications during the primary PCI. Yeah, just 1 minute left. So you have to know how to manage a proximal vessel perf, a distal vessel perf, a dissection. I think when the juniors are taking up such patients in the middle of the night, these protocols should be stuck in the rooms of a cath lab so that there should, at that time, meddling, going through this and that, you should have all the protocols, how to manage an embolized material during PCI. And then with that, I conclude, and I thank the organizing committee for the opportunity given to me. Thank you so much, sir.
Can you put off these lights?
Thank you, madam. Dr. Cicely Mary Majella, madam, is a professor and senior interventional cardiologist, Tamil Nadu Government Medical College and Multispecialty Hospital. Thank you for the enlightening session, madam. I now invite Dr. Asha Malliraman, madam, senior interventional cardiologist, Apollo Chennai, to deliver her talk on invasive strategy in STEMI with late presentation, my approach.
Good morning to all. So my presentation is on invasive strategy in STEMI with late presentation and my approach. So latecomer STEMI, by definition, they present 12 to 48 hours after symptom onset. The proportion of late presenters, this is from US, and that is 16.1%, and 1 in 6 patients present late. The scenario is even worse in India. Late presentation is almost the rule in India. In the Trivandrum registry, it was shown that anybody who presents after 6 hours after symptom onset had worse prognosis. And not only that, the average presentation time in the CREATE registry was 300 plus minutes. This scenario even worsened during the COVID situation. It was 400 plus minutes. So we are battling day in and day out with late presenters for various social, cultural, and educational reasons probably. So I will show with some case examples how we approach these cases. So this is one of the patients who presented with inferior wall MI. He had a critical lesion in the LCX. He came with shock and a heart rate of 120. And this is the presentation. So direct stenting was done in this case. So whenever feasible, a direct stenting is good in a thrombotic lesion. No thromboaspiration was done. It's not playing. It's not playing. Okay. Okay, so a direct stenting was done in this case, and without even thromboaspiration, you can get a good TIMI3 flow. And I've not been doing thromboaspiration for quite some time in the past few years. And this is a 43-year-old non-diabetic who presented with chest pain of more than 24 hours. He had a complete occlusion of the proximal LAD, and you can see that his heart rate is very high, and he had an EF of 35 to 40%. I thought I will just wire and simply predilate with POBA and go ahead. But even wiring was extremely challenging in this patient. The wire was not going through at all, and with multiple maneuvers and gentle maneuvers, it was not going through. And there was probably organized thrombus as well as a very tight lesion. So I just took a plain balloon slightly to open up the distal flow. And even with that, could not get it. Then used a parallel wire technique. With that, a little further progress. Then shifted to a Fielder XT, and finally could get across to the distal lumen. So the lesion was crossed, and it was a very diffuse lesion. Had to predilate the entire length of LAD. And the proximal LAD was stented. I was hoping to do a distal for the diffuse lesion DEB, but the distal lesion showed a dissection flap was seen in the distal lesion. So I had to put another long stent in the distal lesion. A lot of pharmacology is needed in these patients to improve the microvascular dysfunction and plugging. So a lot of nicorandil, my favorite is intracoronary nitroprusside, and also adenosine was used. But finally, you could get a good result. That was the final result. And the patient was asymptomatic and then discharged after 48 hours. So this is another young male, 37-year-old with inferior wall MI. He was lysed elsewhere, and he had ongoing pain. He was on NIV. He was on shock requiring noradrenaline. His LDL was 222. His mother was my patient. So there was a familial hypercholesterolemia. But this patient was not immediately taken up to the lab elsewhere, so they shifted and they came. So whenever you opt for a pharmacoinvasive strategy, it is extremely important that you follow up immediately with an invasive strategy. If the patient is not doing well, you need to do it earlier. So he had an LCX bifurcation lesion. So this was wired, and it's important to keep it simple in these cases. So I wired both the OM and the distal vessel and pre-dilated, and then stented across into the distal lesion, just protecting the first OM, and did a pot, and this was the final result. So keeping it simple is very important in a critically ill patient, and a provisional strategy, as in any other situation, works out well in an MI situation as well. So this was an 80-year-old gentleman, diabetic for 50 years, presented with acute pulmonary edema. He was in pulmonary edema and breathlessness over the previous night, and he presented in the morning. He had sinus tachycardia. He had right bundle branch with anterior wall MI. That was an initial ECG with RBB in an outside hospital, and the next ECG presentation to our ER. His LV was very bad. It was only 30% and it looked burnt out LV. So I was not very sure, and he had pericardial and pleural effusion, not very sure whether to intervene or not. Anyhow, took him to the lab, and he had a single vessel disease, proximal thrombotic lesion with TIMI2 flow, and he was put on a ventilator, tubed even before taking up. And a PTCA was done with initial pre-dilatation with a gentle dilatation with POBA, and a stent was deployed. And this was his final result. We achieved a TIMI3 flow. And this patient recovered pretty well. He was off the ventilator. His creat had gone up a little bit, then stabilized. He was off NIV. He was off oxygen, mobilized. On the 5th day, he was discharged. But sometimes the endings are not very happy. He went home and he was just watching TV after his breakfast, and he just collapsed on the floor. A probable arrhythmic death. He was brought dead to the ER on day 6. So presentation in late, you cannot always achieve success. The outcomes may be guarded, and you need to get these patients early. So this is another patient, acute inferior wall MI, complete heart block, shock, presentation was late. But he has a TIMI3 flow, a thrombotic lesion. Again, it was not cannulating well, but just airmailed the wire. So once you wire the stabilize with the wire, you can get the stent through. A direct stenting was done, and that was the final result. So no thromboaspiration used in any of these cases. I've not touched a thromboaspiration catheter in the last 3 years or so. Use eptifibatide, ticagrelor, or aspirin. Eptifibatide was used only as bolus in these cases. With good pharmacology, direct stenting, or a gentle pre-dilatation, most of the times you can get a good result even without using thromboaspiration. So the BRAVE-2 trial did address beyond 12 hours presentation reperfusion, and it was found that 43% had more than TIMI2 flow and 29% had some collateral flow, which means that they had preserved myocardium, and it is worthwhile going and opening them. And MRI studies have also shown late presenters have a significant amount of viable myocardium, and you can show that meta-analysis has also shown that revascularization benefits even in late presenters. Late presenters have a 35% reduction in mortality compared to not doing any revascularization with either PCI or thrombolysis. But the challenges do remain with late presentation, which are higher heart rates, greater hemodynamic compromise, higher incidence of left ventricular failure. They are more likely to be women, elderly, diabetics, and not present with typical chest pain. Longer hospital delays are noted in late presenters, less likely to receive PCI or thrombolysis, all-cause mortality, 35% reduction with revascularization. Even if you have reduction in mortality, they continue to have higher long-term mortality, and they can come back with heart failure. So my approach is it's never too late to do the right thing. So go ahead, fix it even if it is late. But doing late should not be because of your choice. It is because of inevitably patients have presented. You always need to try to do as early as possible. We need to strive as a population, as healthcare professionals in India, educating our patients to get them to present early, because early is always better than late. In Netherlands, they say the average time from symptom onset to presentation is 30 minutes. We are too far from it. We are almost tenfold away from it. We need to work harder to get patients present early. But for now, we need to battle out in these patients who present late, and it's never too late. Thank you.
Thank you, madam, for a very informative session. We'll take the questions after the final session. I now invite Dr. Hema S. Madam, Associate Professor, Jayadeva Institute of Medical Sciences, to deliver her talk on MINOCA diagnostic and management algorithms.
Good morning, everyone. Distinguished chairpersons and dear WinCAS faculty and WinCAS, thank you so much for inviting me. And I guess the topic given to me is MINOCA, Diagnostic and Management Algorithms. Let's just get down to business. We have 12 minutes and here we go. So why is diagnosing MINOCA so important? Well, we have multiple studies that show us that there's an annual mortality of 2%. And other studies have shown that increased risk of new MI is present very much with MINOCA, and also hospitalization for heart failure and stroke. And also the maximum level of cardiac troponin during MINOCA events is associated with a long-term mortality. Some of the salient points that have been described by Pashupati et al. It occurs in 6% of MI with a female preponderance. The age is likely to be younger and more of women. And people have less hyperlipidemia in MINOCA compared to obstructive CAD, and prevalence of other traditional risk factors are similar, and they have found a 14% hereditary thrombophilia in MINOCA patients. So when we suspect MINOCA, how do we diagnose it? There are 4 criteria: acute MI based on the 4th universal definition of myocardial infarction. So that is serial troponin values with a rise and fall, and at least one value above the 99th percentile, with the symptoms of MI and ischemic changes in ECG, loss of viable myocardium, coronary thrombus, either in autopsy or the CAG. The second one is absence of obstruction in any major epicardial coronary artery based on the angiographic guidelines. That is, absence of lesions more than 50% in a major epicardial vessel without FFR, and absence of borderline stenosis of more than or equal to 30 but less than 50% in a major epicardial vessel with FFR of more than 80%. Third is absence of clinically overt alternative cause for the acute presentation. It could be operative stress, it could be sepsis, arrhythmias, heart failure, and anemia. Fourth is absence of non-ischemic cause of myocardial injury, whether it's myocarditis, Staccato-Bose, or other cardiomyopathy. So the commonest causes have been identified as plaque rupture, erosion, microvascular dysfunction, vasospasm, thrombus, and calcific nodules and SCAD that we have also seen yesterday in the OCT. So let me start with case 1. A 45-year-old male with history of chest pain, no fever, known hypertensive and diabetic, HbF 13 gram percent, TROP positive with rising trend. ECG showed ST depressions and TA inversions in infralateral leads, and echo showed some hypokinesia posterolateral wall, adequate LV function. This is his ECG. And see, we can see the angiogram. LAD is nice, flowing vessel. This is the RCA. We do see a lesion around 30%. And the LCX seems to be all right with a small lesion of 20 to 30% again. So I do suspect MINOCA in this patient. So after I suspect MINOCA, is there any non-coronary cause of rise of troponin? Was there any operative stress? No. No sepsis. Arrhythmias were not there. There was no heart failure, no anemia, and no other non-ischemic cause of elevated cardiac troponin. So after that, what's the next step? Was diagnosis of CAD missed? So after reviewing, have we missed anything? Have we missed reviewing the echo? Have we missed reviewing the CAG and LV angiogram? So we can find out patients who have obstructive CAD, coronary thromboembolism, and SCAD if we carefully review the angiogram and the echo again, and sometimes Staccato-Bose and other causes of cardiomyopathy. So I'll come to the next case. A 58-year-old male, a well-known doctor actually, had chest pain when he went for a trip for 2 hours, and this was his ECG. The CAG to the operator in that place where he had gone for his vacation, it was very surprising. They tried to find the lesion and they kept on searching. The RCA was a small, very small luminal and non-dominant vessel, and this was what they found. So they did search for quite some time. It was inferior wall MI, infralateral wall MI, but that was all the ECG that we could get. And as you can see, we can't see any significant lesion here. But then, after carefully analyzing, they did find a very large OM, thrombotic, which was opened and stented there. He came back to our center where we did an OCT, and where the stent was again expanded. So reviewing the CAG, reviewing all the tests is a very important step in diagnosing MINOCA and ruling out other causes. So we go to step 3. Do you have an IVUS? Sorry, do you have cardiac MRI? Is MRI available in your center? If yes, ASAP obtain the MRI. So we can assess the ischemic and non-ischemic causes of this injury, whether it's MI, whether it is myocarditis, Staccato-Bose syndrome, or other cardiomyopathies. So this is a case as of a 77-year-old female with hypertension. ECG showed TV inversions in precordial leads. They did a LV angiogram also, since they didn't find significant lesions in the angio. They did a LV angio, and then in the LV angio, they did suspect Takotsubo cardiomyopathy. But after the cardiac MRI, you can see that there is gadolinium enhancement, a transmural enhancement, which did tell us that this patient had an MI. It was a MI because of an embolic genesis. Another case of a 60-year-old female admitted due to chest pain, dizziness. This patient also was treated for breast CA with chemo and radiation. ECG showed elevations in the ST precordial leads, and echo showed apical dyskinesia suggestive of Takotsubo. The cardiac MRI on day 15 showed normal-sized LV with, of course, hyperkinesia in the basal segment and apical hypokinesia, and accordingly, the CMR did show clear increased edema in all the apical segments, suggestive again of Takotsubo cardiomyopathy. So another case, a 61-year-old male without any cardiovascular risk factors admitted because of chest pain. On day 4, cardiac MRI revealed a normal-sized ventricle with regional hypokinesia. The viability sequence was done, and LG showed widespread subepicardial and mid-wall signal increase. Now that is suggestive definitely of acute myocarditis. So that is how cardiac MRI is very useful in diagnosing. And then after that, if we don't have any MRI or the LGs absent, we go for a OCT or IVUS to assess coronary lesions. So what do we see in OCT or IVUS? We can detect plaque disruption, erosion, rupture, coronary thromboembolism, and SCAD. So a small case to show you that. A patient with a chest pain and ST depressions in anterior leads. Here the OCT image shows, the first you can see a plaque with a thin fibrous cap. And then the second one shows a small fibrous cap with ulceration. And the third arrow shows minimal luminal irregularities due to thrombus remnants. The second case shows you calcium deposits with thrombus in between. So erosion is seen around in 30% of cases with OCT by Gerbond et al. It was found in 50% of cases by Opolsky in cases of Minoka, that is thrombosis without ulceration. Plaque ruptures can be seen in 60 to 70% of cases in ACS and is very similar in Minoka.
Recording in progress.
Approximately 1/3 of patients with Minoka can have plaque disruption in IVS. So SCAD can also be diagnosed by OCT again. We can have type 1, type 2, and type 3 dissections we saw yesterday. It's a type 3 dissections that very much mimic atherosclerotic disease. And here we can see the OCT with a type 3 dissection with a vessel hematoma. So now we have done OCT, and what's the next step? If it's unavailable or absent, we can go for provocative testing of CMD to find out whether patient has coronary vasospasm, patient has coronary microvascular dysfunction. So vasospasm is actually, this is how it's seen. And with nitroglycerin, that is the next slide, the next picture that you can see, the vasospasm is resolved. In OCT, it has been identified that these people can have a new feature called superficial bumps. So this was identified in 2.1% of patients with Minoka. Microvascular testing can be done non-invasively by PET and cardiac MRI, and it's actually safe, and arrhythmias are rare, contrary to the initial belief, and it helps identify those patients with poorer outcomes. So by making a diagnosis of CMD, it improves the rate of appropriate therapy with CCs on discharge and other effective antianginals for vasospasm. So this is the diagnostic algorithm, but do we have a management algorithm? So it's very difficult. We don't have any standard management algorithm because Minoka is a heterogeneous condition, and the current guidelines are based mainly on the expert opinions. Minoka benefits from cause-directed treatment is what we know, and secondary atherothrombotic prevention measures should be considered depending on the etiology. So what does AC guidelines tell us? When you have an initial working diagnosis of Minoka, it is recommended to follow the diagnostic algorithm to differentiate true Minoka from alternative diagnosis. And also, patients with final diagnosis of Minoka with unknown cause may be treated according to secondary prevention guidelines for atherosclerotic disease. So what do we know about the treatment aspect? Now we know that dual antiplatelets are not helpful to prevent MACE. Statins, of course, are very helpful. Beta blockers, again, are not very beneficial. ACE inhibitors, ARBs, are beneficial. Calcium channel blockers have found to be non-significant, but still in cases of vasospasm, we do use it. Plaque disruption patients, secondary prevention is advised with statins, aspirin, ACE inhibitors,
Recording
ARBs, lifestyle
stopped.
modification very much, and cardiac rehabilitation. In addition of a beta blocker and P2Y12, like we saw, it's not of much use. cognitive vasospasm, the use of a short-acting nitrate along with the CCB is shown to be effective. And when angina is refractory to short-acting nitrates, long-acting nitrates can provide symptomatic relief. Now coming to microvascular dysfunction, studies have shown treatment with beta blockers, long-term arginine, dipyridamole and ranolazine can give symptomatic relief, and also the use of aldosterone with AC inhibitors and ARPs. In SCAD, medical versus revascularization therapies, 70% of SCAD does resolve, as we already know, on repeat angiography. And MI guidelines support the routine use of low-dose aspirin, beta blockers, AC, ARBs, if there is LV dysfunction. And one important thing is, since MINOCA has predominant women class, we have to warn about the heterogeneity of AC inhibitors and ARBs in our patients. Regular exercise and cardiac rehab is beneficial and safe for MINOCA patients with SCAD. DAPTs again to be avoided. So when we have left main dissection, ongoing chest pain or ischemia and ventricular arrhythmias and shock, we have to consider revascularization in SCAD. So these high-risk patients should be put on cardiac implantable devices like IIBP, ECMO, LVADs, stabilize the patient and then take the patient for interventions if required. CABG, however, should be reserved for patients with high-risk clinical features, either LAD lesion or more than 2 proximal lesions when PCI is not feasible and left main dissection involving the LAD or left circumflex, but CABG usually fails because of a competitive flow. So anginal pain after episode of MINOCA should be treated again as usual with beta blockers, calcium channel blockers or long-acting nitrates as required. In cases of LV dysfunction, the same treatments of ARBs, AC inhibitors, beta blockers and other evidence-based treatments of heart failure. So one of the important studies that we need to understand is the pilot study by Prati et al., where they compared the effectiveness of DAPT versus angioplasty and stenting in 31 patients.
Madam, one more minute.
Sir.
One more.
Yes, sir. And conservative approach is the advised therapy. So PCI can be done only in presence of high-risk anatomical features, including severe proximal lesions, LAD, left main, and low TIMI scores and ongoing ischemia. So the take-home message in my talk is there is only one way forward in a suspected case of MINOCA, and that is we follow the diagnostic algorithm and treat according to the cause. Thank you.
Thank you, madam.
In the interest of time, we'll move to the last session and then take questions. The first session, if we delay our session, the whole day will go for a toss. Can we?
I now request Dr. Ruchi Gupta, madam, HOD, Director Cardiology, SR Kala Hospital, Jaipur, Rajasthan, to deliver her talk on complete revascularization in ACS, angiography, physiology, or imaging guidance.
Does this work? Good morning, everyone. First of all, I like to thank the WinCars Association for having me here for this session and such an important topic. Thank you, everyone, for being here. So today's topic is complete revascularization in ACS, angiography, physiology, or imaging guidance. So when we talk in STEMI, angiographic significant multivessel disease would mean, apart from the culprit artery, the non-culprit artery having a lesion more than 70% diameter stenosis. Physiologically, if we talk based on FFR, a value of less than 0.80 would mean significant. And we talk about imaging like OCT, then we would be referring to TCFA, that is thin cap fibroatherosclerosis. So I'll take you down through the history of various studies which have happened over the years and have led to the conclusions and guidelines for today. So beginning with PRAMI, that happened in 2013. So in PRAMI trial, there were two groups. One, the only culprit artery PCI.
Recording in progress.
PCI of the non-culprit artery as a preventive PCI. So the study revealed that the occurrence of composite primary endpoint, that is death, non-fatal myocardial infarction, and refractory angina, was higher in the patients that received culprit lesion only PCI than in the ones who underwent preventive PCI 2 at a mean follow-up of 23 months. The timing of treatment of NCL was not investigated in this trial, though it was a favorable trial for multivessel PCI. Moving on to culprit trial that happened in 2015 and was published in JACC. Angiographic guided complete revascularization yielded a 55% reduction in the composite primary endpoint when compared to a culprit-only strategy. Now, when we move to the physiological assessment, we have two parameters for doing that. One is stress echocardiography and the other is FFR. So we don't have many studies on stress echo, just one was available, and mostly it is done on patients who have CTO, where doing an FFR was not possible in the non-culprit lesions. Most of the studies are done on the basis of studying FFR versus angiographic non-culprit lesion arteries. So when we talk about the NAMI, it was published in Lancet 2015. So this was the first FFR guided trial which compared FFR versus angiography for deciding on whether the non-culprit lesion needs to be stented or not. So in the NAMI 3 prime multi trial, the authors tested a strategy of complete fractional flow reserve guided NSL's revascularization in patients presenting with STEMI compared to a culprit lesion only strategy. The result was mainly driven by fewer repeat revascularization. When we talk about compare acute trial, it was published in NEJM 2017. So the investigators randomized patients successfully treated with primary PCI to receive either a complete revascularization of NCLs guided by FFR or no interventions. Once again, the treatment of NCLs conferred better outcome at 12 months follow-up. This is just an algorithm of this study. So based on all these studies, if we see all the multivessel STEMI patients, they were divided into two groups. One was the conservative approach, where we treated only the infarct-related vessel, and the rest of the treatment was medical management. Only on the basis of ischemia or other symptoms, we tried to invade the non-culprit vessel. Whereas in the other arm of the studies, they had two groups. One was aggressive and the other was intermediate. So in the aggressive group, we had the studies like PRAMI and culprit, where we stented the non-culprit artery based either on angiography or on FFR. Both the studies, in fact, actually used angiography only. In the intermediate group, we had the NAMI prime multi trial, which used FFR. And then the compare acute trial was an aggressive trial which used FFR as a mode to decide on which NCLs need to be treated. Now cross AMI, this is the only trial which was available as a trial to compare the invasive angiography method to the non-invasive, that is the stress echo, to assess the non-IRA vessel, and it showed non-inferiority of the non-invasive technique. This is a table to formulate. So here they found that there was a 14% risk reduction when stress echo was used as a parameter to treat the non-culprit vessel as compared to the angiographically decided and treated non-culprit vessels. So there was non-inferiority of the non-invasive method as well in this trial. Based on all these trials, the ESC 2017 said that because of the aforementioned trials, they did demonstrate a different mortality benefit between complete and incomplete revascularization. The ESC guidelines designated a class 2A level of recommendation to complete revascularization in patients with STEMI and multivessel disease. So these studies happened before 2017 and these guidelines were published later on. After that, we moved to the later on guidelines. So 2019 onwards, COVID happened. So the latest publications are between 2022 and 2023. So FRAME AMI was published in ESI Congress 2022. It was an FFR guided study. So acute MI and multivessel disease and FFR guided complete revascularization was found to be superior to an angiographic guided one with significant reduction in death and MI. So this study mainly had a comparison between decision on the treatment of non-culprit vessels taking two arms, as one was angiographically deciding which was the severe lesion and the other was FFR. So they found that when we used FFR, then there were many patients who were found to be lying between 50 and 70% stenosis range, and on FFR the lesion was found to be less significant. The analysis was more than 0.080, and they were deferred in favor of medical management. So when we used only this criteria, then there was a significant reduction in death rate. Maybe we had chosen not to stent few patients who lied between 50 and 70% diameter stenosis. Now, the percutaneous complete revascularization strategy using sirolimus eluting biodegradable polymer coated stents, that is the BioVasc study, which was published in Lancet 23. So it also compared the FFR guided mode with angiographic and gave positive results. Now we move on to the complete trial. It was complete versus culprit only revascularization to treat multivessel disease after early PCI for STEMI, published in November 2023. So on what basis was this trial done? So first of all, they said how should we assess the non-culprit vessel, either on the basis of physiology or intravascular imaging. So after complete trial, we started thinking about doing imaging, intravascular imaging, to find out the severity of the non-culprit lesions as well. So it was found that the benefit of complete revascularization was maintained either when performing PCI during index hospital or early after discharge, no greater than 45 days after the primary event. And also this had an OCT arm where some patients were tested on the basis of OCT whether they should be taken. So the patients who had a thin fibrous fibroatheronoma, they were taken for revascularization and positive results were found. So this should be considered when dealing with borderline, that is, it's a sub-analysis in complete trial, obstructive NCLs, that often atherosclerotic plaques that lead to ACS occur at sites of angiographically mild coronary artery disease. That means the lesion angiographically is between 50 and 70% or maybe less than that. So they may drive the paradigm shift from treating showed higher vulnerable plaque morphology as compared to non-obstructive lesions, that this may explain the benefit of treating those lesions. So what we understand from this is that there are patients who are angiographically, they fall into the category of mild non-culprit artery lesions, but when OCT was done on them, even they had lesions who had a thin cap fibroatheronoma, and the patients when treated were found to be benefited. So now we move on to this trial, combined FFR OCT trial. So in combined OCT trial, why was OCT done? They were found that in acute settings at times, because of the adrenergic milieu, the response to adenosine could be blunted, and the lesion severity may be underestimated by FFR. So there were patients who the value was coming as more than 0.80, but when the patients were taken for OCT, they were found to have a thin cap fibroatheronoma, and they were when this trial was taken up for 18 months, then a significant benefit was shown in terms of MACE. Multi-star MI trial happened and was published in October 23. So it talked about hemodynamically stable condition with STEMI and multivessel coronary artery disease, and they said that immediate multivessel PCI was non-inferior to staged multivessel PCI. So I think this is the only study which was talking about aggressive and immediate multivessel PCI and was shown to have positive results. So based on these studies which happened, the algorithm for today is that first of all we do an angiographic evaluation of the non-culprit lesion. If it is more than 70%, we decide on correcting it, be it angioplasty, be it bypass, depending upon the complexity of the lesion and or the status of the patient. If the lesion is between 50 and 70%, then we do a functional evaluation, either by a stress echo, if we have a CTOs as well, or by FFR or IFR. If the FFR or IFR is less than 0.80, again, we choose the treatment by doing either a PCI, staged PCI, or sending the patient for complete revascularization by bypass. In the cases where FFR is more than 0.80, consider intracoronary imaging in selected patients, especially diabetic patients, the patients who've had previous MI, young patients, which suggest high risk, and aggressive secondary prevention should be taken on if such plaques are found.
One more minute, madam.
So we have non-STMI ACS also. There are equity trial and SMILE trial which happened. Both showed positive results and 2 trials are ongoing. In cardiogenic shock, there was a culprit shock trial which said that only the culprit vessel should be treated when we are doing a primary PCI in a patient who's in shock. And the algorithm follows that the single vessel should be treated. The stage procedure can be done depending upon when the patient is stabilized and has shown clear mortality benefit when the procedure was staged rather than being done in the same sitting. So as on today, the 2021 ACC AHA guidelines, they put the selected hemodynamically stable patients with STEMI and multivessel disease after successful primary PCI for a staged PCI of a significant non-infarcted disease as a class 1 indication. So that's how we've evolved over the time till 2021. It's the same algorithm. After the studies which I showed you till 23, presently we are following this protocol which says that the patient is brought in emergency. First we do the angiography. Depending on the culprit artery is treated. If the patient is in cardiogenic shock, we say an absolute no to treating the further vessels in the same sitting. And if there is no cardiogenic shock, we further evaluate the patient doing whatever method we have, either FFR or OCT. And depending upon the nature of the lesion, the further action needs to be taken. However, the trials in future are happening like FIRE and SLIM trial, which are ongoing and the results are awaited. Maybe we have new guidelines which support a multi-vessel revascularization in the same sitting or before discharge in other, looking at other parameters also. But as of now, these are the latest are the 2021 guidelines and we are following the dictum, the algorithm which I just showed. Thank you very much. Very happy Holi to all of you.
Now the forum is open for discussion.
Yeah, any questions from the floor? Actually, I just request, one, the timer should be here. Second, speakers, please leave time for discussions. Sujata, if you have your permission, we'll go ahead with a few questions. So, any questions from the floor? So I think I'll take it one by one that, for the first talk that was done on intravenous antiplatelets by Dr. Shilpa, in real life, cangrelol, finding cost is a very important factor. Second, we use what we are familiar with. And we are all, familiar with two, tirofiban, abciximab. Cangrelol is very, very, very select, Maybe for a patient who after an angioplasty needs surgery immediately, soon, within 4 weeks, 6 weeks, before you can get the antiplatelet on. So, literature in its place, but practically if you were to just summarize your talk in 2 lines, where you use it, and if you would like to say something. Because, literature is there in real life. The aim of us was really to get to hone our skills and get better and ask the questions that you're shy to ask anywhere else. So your take on the antiplatelets, on the
yes, ma'am. One subset of patients where it is really helpful is those who are very sick, intubated and in shock. So when we are taking these patients for primary PCI, we want immediate antiplatelet effect, we can use cangrelol.
So the cost of cangrelol versus like the RCA you showed, you can even use, tirofiban. It's not right. It's not going to give you. I think cost-wise, cangrelol is not so easy to use. And in a clear-cut committed angioplasty, it doesn't stand much of an advantage on the 2B3As we are used to using.
And the patients who are awaiting CABG, where you want the antiplatelet action to disappear quickly, which is very less. Very less,
so
yes.
any, I mean, so those who are not using, don't think you're missing on something. It's all right. If you're comfortable and you know your other antiplatelets, please stay with them. Right? So, yeah, yes, Yotsa ma'am.
So, it's not that it is not an effective. As she already said it, the subgroup of the people, definitely it is going to be the much more the helpful. And the major advantage is in immediate some complication occurs, you can tackle the much better. At the time, the major concern was about the bleeding, but nowadays the bleeding is not a much problem about it. I think it is effective in subgroup.
Yeah, they are very effective, and balancing of cost and use and how to use it. And bleeding, I think if you know heparin, most of these drugs you're very comfortable using.
The current ESC guidelines say that patients who have NSTMI, most of us, they give dual antiplatelet, but the recommendation is to give only aspirin and heparin. But if you are taking to the lab and then do an angiogram, if you find that there is a lesion which needs to be tackled, probably there may be a role because it works faster. But otherwise, I don't know, because of the cost and all, I don't think. What do you think?
Yeah, so it's balance. I mean, you know your tools and know how to use them. That's mostly, I wouldn't be judgmental at all on this.
Good morning, everybody. Ma'am, I was just wondering, maybe like in select group of patients, the class of indication I thought could be, taken higher up. Like now, currently 2020 guidelines say 2B. Sorry, yeah. So in select group of patients, I think we could still use it. And
yeah, you can use it. Be more confident about it. It was very well discussed how to use it.
Yes.
But don't discard what you already know.
Okay.
Now, in the second talk, Dr. Cecily had discussed primary PCI. So I have only one. We don't flee. Intelligent pause is not a flee. So we don't flee any of our patients and knowing when to stop. I think flow is the best thrombolytic. So when it says flow, whatever you showed, if there's a flowing vessel with thrombus, pause, but we don't flee really.
There is a recent publication in NEJM where in a patient who has a thrombus, direct stenting, if there is not large burden of thrombus, direct stenting is better than, in terms of long-term results, direct stenting and thrombus aspiration whenever there is a large thrombus burden is better than ballooning and then doing a procedure, stenting.
Thromboaspiration, Asa Mahila madam told that 3 years she has not used thromboaspiration, but now as we are moving towards penumbra for coronaries, so definitely there should be selective cases where we should use.
So I think now Asha is seeing patients earlier in the course of their STEMI, and their duration to pain is there because if they are mainly platelets, so 1 or 2 cases you showed, they were very well collateralized. So a collateralized vessel with a focal lesion, you're not going to get much of a thrombus. But the typical cutoff with a huge thrombus, late presentation that we see more is, they will need, and I think the key is you have to pass the wire down, then gauge the thrombus. And if it's a high thrombus burden, no questions asked, you will need to do something. I think the trials have been unfair to us from third world where we've seen high thrombus burden. We've used it, of course, from a 60% use, we've come down to a 20%. That's the rationalization. But it's reasonably high compared to others. So the trials, by giving it to everybody, showed the devices were bad, but we know that in niche, they are niche devices, and there will always be a place for them.
Yeah, I do agree there's a place. I do use in stent thrombosis, I definitely use thromboaspiration. But what I'm trying to say is you don't have to use it in every case.
Yeah, so, and the other part I think we've missed discussing totally is there will be a patient where you need a thrombolytic. And knowing how to use the thrombolytic in a lower dose, how much 2B3 you have given and what you've not done, and antiplatelet loading, because these late presentations which are high in fibrin, learning to use a thrombolytic and what is on your shelf. You can use TPA, you can use your urokinase. If you don't have anything, you can use streptokinase, but going down on the dose, giving a little bit, knowing your ACT, waiting, letting it dissolve is very, very important. So I think we've covered most topics, and in the end, at the last topic that was done on complete, you must understand that to do these trials, they just could recruit 15 or 20% of patients. So these are very select, 50 to 70% where they did FFR, and when they did FFR, 30% of the patients were out. You know, so 70% of patients will need a stent. So this is a very select niche group. And for a majority of the patients, critical multivessel disease, whether it's a CABG or it's a stage intervention, you've made it. They're not even included in these trials. So most of the decision making that we are doing is out of these trials, and these are not meant for that. I think if there are no more questions, we'll wind up the session. Thank you all the speakers, and thank you our lovely audience. But please open up and ask questions.
Just a small presentation for all the speakers and the chairpersons. I request Dr. G.V. Reddy. All the speakers, please come onto the stage. Dr. Shilpa, Dr. Hema, Dr. Asha, Dr. Cicely, and Dr. Ruchi.
I think it's very important to celebrate each of the speakers and everybody who's here, you know, long overdue and long needed.
I now request Dr. G.V. Reddy sir to hand over the memento to Dr. Shilpa madam. I now request Dr. Rupa Salwan madam to hand over the memento to Dr. Ruchi Gupta madam. I now request Dr. Jayashree Karge sir to hand over the memento to Dr. Asha Maliraman madam. I now request Dr. Shashireka madam to hand over the memento to Dr. Hema S. madam.
I request Dr. Asha ma'am to please hand over the mementos to all our chairpersons and experts. Okay, moving on. Our next session, we have 2 live inbox cases. I request Dr. Shiba Takkar Chabra to please come onto the stage to moderate. Dr. Anupama Hegde and Dr. Asha Mahilmaran will be the chairpersons for this. Asha ma'am, please stay on. I request Dr. Saiko Takahashi, Dr. Mamas, Dr. PVN Kumar, Dr. Natalia Pinilla, Dr. Rupa Salwan, and Dr. Ramabala to be on the stage as expert panel. Thank you. Dr. Sarita Rao will be presenting.
So very good morning to all of you. We are indeed privileged to have in the city of destiny, as we call it, the greatest pearls of wisdom from all across the globe. A very warm welcome to all my co-chairs. And well, we have none other than Dr. Sarita Rao, President WinCars. And as she looks at me, we know that the determination and aggression in hers is going to tell us as this live case unrolls. All over to you, Dr. Sarita, ma'am.
Thank you so much, Dr. Shiba. And without any further ado, we'll go to the case in box. I need an audio on this, please. From Apollo Hospital, Indore. So our patient today is a 65-year-old lady who was admitted with complaints of heaviness and chest pain, which was associated with shortness of breath and back pain since the last 1 month. Now, this patient was admitted with chest pain for the last 3 days in another hospital. An angiogram was done outside, and the angiogram revealed a critical triple vessel disease with heavily calcified lesions in the LAD and the RCA. The circumflex also had an 80% stenosis, and this patient came to us for further treatment. So we stented her circumflex 2 days ago, and an FFR of the RCA was also done, which was non-critical. We did try to wire the LAD that day. We wired it. However, it was so heavily calcified, even an IVUS catheter failed to cross. She has a good ejection fraction. On the echo, it's about 65%. So now let's look at the angiogram. Can you show me the angiogram? So this is the angiogram of the patient. You can see the lesion in the circumflex. Next, please. This angiogram was done outside. This was the LAD. Next, please. You can see the longish lesion in the LAD, very critical stenosis. Next, please. This was the RCA. Next, please. So now this patient came to us with this angiogram. We did an FFR of the RCA. It was non-critical. The LAD and circumflex were both deemed to be tight. And I'll just show you that. Can you play it? Yes. So this was the LAD. We wired it, but an IVUS catheter failed to cross. So we did FFR of the RCA. Next, please. The circumflex lesion was successfully stented. Can you show the final shot of the circumflex lesion? Can you just play the final shot of the circumflex lesion at its final state? Yes, please show that. So the circumflex was done. Now we are back here today to deal with the LAD. Now can you show the shot that we took today? I'll just press the fluoro for you. Yes. So this is our first shot today of the LAD. You can see there's a lot of angiographic calcium also over there. Next, please. Now, at this point, we tried to take in an Opstar OCT catheter, and again, we failed. So we don't have imaging as yet. Now, the question to the House is, what is your strategy at this point? So House is now open for discussion. We have a lesion in the LAD. We are able to cross it with a wire. We've not been able to get an IVUS earlier. We took an Opstar because it tracks very well, and we failed to cross with that too. And we have visible angiographic calcium. At this point, what do you think we should do?
So why would you need an OCT for the distal? What is in your mind when you're doing an imaging? Because the proximal lesion needs to be assessed. The calcium is in the proximal LAD, and this is beyond the diagonal, which also has some stenosis, and it's critical. So I would like to ask that why would we image that distal LAD, because, and it's tight, so you would expect to predilate that vessel. I'd be surprised to need an imaging to even start the procedure. But the imaging of the proximal lesion to know what is the strategy. Are we from top down? And what are the OCT parameters where we think it's safe to leave the proximal LAD lesion is what I'd want you to discuss.
Okay. Some further comments from Dr. Mamas, Dr. Natali?
So I think if we try the imaging catheter and doesn't go, you can also try a balloon to see if it goes. It's usually helpful too. You get a second wire, like an extra support wire, and usually the imaging catheter goes. The segment of the LAD is particular we have to assess that very careful because that segment of the LAD has a lot of motion, and surprisingly, we get to see like nodular calcium in that segment quite frequently. So I think that needs to be assessed. And it's not infrequent, some of the segments in that segment of the LAD is intramyocardial as well. So it's kind of a dangerous place to do PCI. I agree we also need to assess the proximal LAD to see what is the morphology.
Dr. Mamas.
So, I mean, it's a great case, a great discussion point. I mean, you have that mid-LAD lesion, looks quite calcified, quite significant, involving the bifurcation, and the proximal, more moderate lesion. If I was doing this case, I would probably pre-dilate with a 2 millimeter balloon distally, and then do my imaging. I think it's going to be critical to assess the degree of calcium, whether it's nodular calcium, whether it's circumferential, the thickness, and that will really guide where you go thereafter, whether you do rotablation, whether it's more focal that you can do lithotripsy with. In terms of assessment of the proximal vessel, I think the MLA of that region will give you some indication of whether it is or isn't going to be likely to be significant, but I would probably continue and finish off the PCI distally and then pressure wire the more proximal lesion, because I'm always concerned when you assess significance just by virtue of MLA alone. I think we really should be using physiology.
Dr. Siko?
Yes, by angiography, I think that there is no really severe calcification by angiography. So maybe I do the OCT, and then I will decide what to treat. Maybe we need a rotablator or other debarking device, and then I will decide by imaging and which stent length, or we don't place the stent. We will decide after the OCT imaging.
So the diagonal you planned, the ostium from the diagonal wasn't really a long lesion, but mid part of the diagonal was diseased. But I believe it did not subtend a greater area of myocardium. So
Yes.
Probably you're planning to leave it as it is.
We're probably planning to leave the diagonal. Now, at this point, very interesting points put forward by the panel, and we have a great discussion, a lot of diverse views, and a lot of similar views also. So we failed to get the imaging further down. We did take an imaging of the proximal segment, and we realized that there was a good amount of calcification even in the proximal segment, and the proximal segment was also significantly diseased. And now we have calcification. We have a long lesion segment now, and so what did we do? At this point, we decided that we would require some upfront calcium modification technique. So let's look at what we did. So we're at this point that our OCT failed to cross, and it's a very tight lesion, and we had to decide what we wanted to take. So we decided that the only thing was crossing at this point was a wire. We decided to go for an upfront orbital atherectomy. We've taken a microcatheter and changed the wire, next please, for a wiper wire, because the orbital only goes over the wiper wire, and we've just got the orbital in, and we're planning to track it ahead. Now from this point only, there's so much calcium, we're having difficulty in tracking, so I'm taking a glide assist and trying to go in. Can you go to preacranium? Break open. Okay. So we are starting the orbital atherectomy. We had a jump over there. So the idea is that we first need to open the first lesion before we go to the second one. Moving at 1 millimeter per second, the speed of 80,000. Somebody give me a time count. Okay, 25 seconds. Coming back. You need to come back and park your wire in the right place, your burr. Give it a little time to breathe. Hemodynamics look okay. Let's take a slight puff and see if there's any dissection there. We're okay? Okay, right. So we waited 30 seconds. We're ready to go now again. can listen to the auditory changes which are occurring. There's a change in the pitch which occurs every time it hits a very tight calcified lesion. Can somebody give me a second count? Okay.
What was the size of burr
Need to come
you
back a
used?
bit and park it.
What was the size of your burr?
It's a 1.25.
Okay, we're ready to orbit again.
Burr size.
A lot of resistance at this point.
The diagonal also appears to be a large vessel. Would you consider a DEB or something? Subsequently, once you fix the LAD?
What's important during this is that
So
we take a check in between to see if there's any dissection. Let's orbit some more. We had a jump there a little bit. There's a change in pitch. The distal lesion is very tight. It refuses to cross that. Looks better. Yeah, we're through.
Okay, so 2
Looks
points
good.
which were raised. One, did I balloon it? No.
Yeah.
Whenever I'm going for orbital,
I think now we
don't
take it out.
balloon it. Because the moment you balloon and if you have a dissection, you can't take the orbital
Center
catheter
it, please.
inside. Orbital is contraindicated in the presence of any dissection, it will create a curve. Because orbital rotates circumferentially, it will find the dissection. and it
Looks
will curve at that
significantly
moment.
better. We're now going ahead and taking a microcatheter, changing the wiper wire again back to a run-through floppy. Yep.
Actually, what we are not clear is the decision for an orbital atherectomy for a distal LAD lesion.
So there were lesions at 3 points. We had a lesion at that point where the diagonal was coming in at that point. We had a lesion at the distal LAD, which was not being crossed by anything. And we
So,
had a lesion at the proximal LAD.
We've been able to cross in with a balloon now. This is a 215 test, please.
So by protocol, do you
Yeah.
always opt for orbital?
So that's the point where we are.
Would you have
Please give a
chosen
shot.
other technologies for calcium modification, or?
So in this case, we have
You'll have
two
to go up till
options.
there anyways.
Freeze the image
One
when
is-
the talk is going on here. When discussion is going on,
Test,
kindly
please.
freeze this image.
Test. Okay.
So what's your thought here? I mean,
Inflate.
presumably you're going to do some stenting, but are you considering a hybrid approach with drug-coated
That's it.
balloon for more distal vessels? So, at least
So
you
this is
retain the
post-ballooning and
ability
post-dilators.
for
The
lemur.
vessel now seems to be looking
So maybe
much
once
better.
you stop this, then we can have the
And
discussion. Maybe hold it if possible, or whenever it's
we're now
possible
going to
hold
try
it.
taking in the OCT catheter and have a look inside how it looks.
Would you like me to pause?
We can have a discussion once she's able to stop this. and-
Dr. Mamas, I missed your question. I paused it.
No, so I mean, so it's, you're doing great stuff here, but what I was going to ask is, in terms of your strategy, are you thinking to stent this wholly, or are you thinking to use a hybrid drug-coated balloon? Because if you do a long metal stent here, you're going to lose the ability for a lemur to LAD down the future. So, just to hear your views about hybrid DCB approach versus full DES approach.
Yes, so that did cross our mind because it was a long lesion. Initially, when we had looked at it angiographically, we thought that we would get away with stenting the mid and distal lesion only. But when we took the imaging catheter in, we got a totally different view. I'll show the imaging views when we finally managed to get in. And we found that it was diffusely diseased LAD. And we had significant disease in the proximal segment also. So at that time, we also considered doing 2 stents, one in the proximal segment and one in the mid-distal segment. But then again, imaging showed us something else. Imaging showed us that there's diffuse disease, you don't have a landing zone anywhere. So, but at that time, we'd orbited, we had ballooned, and we had significant damage to the vessel wall. Just doing a DEB and coming out at that time didn't make us feel comfortable. So at that time, first we stented distally, then we looked at the proximal segment and we decided that no, we'll have to stent this too. So the strategy evolved as we went across in the case. So now we're finally taking the imaging in.
Can I just...
Save it, please.
As a word of caution.
And we are seeing a lot of deep calcium, a lot of 360-degree calcium, and a nodule at one place. We haven't got really very optimal images, so we are just planning to take one more run. Okay? Yeah, can I take that out? Yeah, just show me this and let me take it out. There's a little slow flow. Show me the wire, please. Can you give me a vessel length and a vessel size? Okay, 2.29. So at this point, what we have is a long lesion length. We also have an osteal disease, which is significant. And we've changed our strategy now to a two-stent strategy. So distally, it's a low caliber vessel. We are planning to go in with a 2.2538 Sierra stent. So this stent is unique in the fact that it has amazing expansion capabilities and very good trackability. Yes, it's a huge, almost 300 degrees of calcification at the ostium and thick calcium. So let's see, we'll see what we can do for that too. Let's secure the distance.
There's a very beautiful observation made on the OCT that what looks like a stent on the pre-run is an artifact caused by spinning of the wire. Natalie would just tell us about it?
Yes, Natalia.
Yes, so usually if your wire is very distal and is stuck in the small vessel, the catheter doesn't rotate. So that's why you see lines like looking like a stem, but it's called the nerve artifact. So it is that it was non-rotational imaging. So that's why it looks like a stem, but it's not a stem.
Yes.
But more concerning is so much calcium in here.
Yes.
And in the proximal segment, you had a very small lumen area with very thick calcium, almost circumferential. And as you're saying, Sarita, you start the case with a plan and you get the imaging catheter and everything changed. Because now you have multifocal, heavy calcified, concentric, thick calcification throughout. And as we were discussing yesterday, then what do you do next? Because the devices we had for these, which is balloon-based, and we had the shockwave, is 12 millimeters length. So when you had a case like this that has not one, but multiple ones, and you have 80 or 120 pulses with the new shockwave, that's not enough for this vessel. And doing more ROTA is probably not going to change. Maybe we listen from the other panel. It's not going to change because you're going to keep decreasing the thickness, but you don't fracture. So what will be next? Yeah.
Excellent point made by Dr. Natalia. When we start a case, we go with an upfront notion. And when we image, everything changes. That is the beauty of imaging. That is the beauty of OCT in this case. I started with a preconceived notion of maybe just stenting the mid-distal. I started with the notion that, okay, let's take an atherectomy device. Now I find there's a long lesion, I find this thick lesion, and now I know why I can't take ROTA and I can't take shockwave. A shockwave is not going to be enough. Even the C2+ catheter is not going to help me modify the entire vessel. Not enough pulses. And 2 balloons, too high cost in our sector. And ROTA ablation, only superficial calcification. What am I going to do with the deep calcification? So let's move ahead and see what we did. We started off with taking the distal stent at this point.
Center it, please. Can we have a little shot? And we can see
How does
Sunil
that
just
look?
moved
Do you
it
like
to
a
the
pull?
background in the video.
Sarita, I want to ask you, how are you using the
This is a
OPN
dot to dot.
balloon
Just one
here?
second. I'm
Are you
opening the
using
system.
it, the
Don't
super higher pressure, the OPN?
test, please.
So Dr. Natalia has a question whether we are using OPN. Yes, we
Push.
frequently use OPN
Test.
NC. And
Yeah.
it's a unique balloon twin layer technology. Allows you to
Hmm.
go to extremely high pressures with a special inflation device that you have.
Uh,
And it doesn't
do you want me to push
upsize.
it distally?
And there's literally no dog bonding.
You're okay with
so
it?
yes, it's a major
Okay.
bailout situation for us.
Okay.
We usually
Deploy.
use it after the stenting.
Decision
It's
not
one
to
point
protect this
where we
diagonal.
need to post dilate.
The decision not to
Give me a
protect the
2.5.
diagonal.
Right.
So at this
So,
point,
the
we've
proximal
deployed the
segment of
stent.
the diagonal
The stent tracked through very
didn't look very
well.
diseased to me. The disease was
Side
more
branches are
distally
flowing.
down.
We are
I thought
planning
that
to
I'm
go
not
in with a
going to
post-dilatation
compromise it.
balloon.
And especially when I'm
This is a 2.50. Can you center the machine, please?
You can pause it and then you can talk. We are not able to listen what you are saying.
okay.
Inflate, please.
Pause this. Can you pause it?
12.
I can pause it. The only problem is we'll exceed the time and then Dr. Sujata will be out to murder me.
No, just mute it and let it keep running. We can discuss as it.
14, 16, 18.
So this is, we place the stent and we're just doing
Yeah,
the
opened up.
post-dilatation.
Deflate.
What size is it? What size?
Yes, go up.
This
18.
was I'd mentioned it, I think this was a 2.2538.
Some guide catheter damping deflate.
Yes, post-dilated with a 2.5.
Looks good. We'll have to burr backwards.
This is a Zion Sierra.
That would be
Great
the
part
only
about
way.
Sierra is a 2.25
White,
goes
can
up
you go
to a
cranial? Let's see if I'm
3.5.
inside. We're just going to pot the proximal portion of the stent. Inflate. 12, 14, 16. That's it. Deflate, please.
Size
Can you-
of the pot.
The size of the balloon, ma'am.
That was a 2.5.
So now we are
which
done
we
with the
were
mid and distal segment of the LED. Now the question that comes
use
in
the
is,
same
how do you
balloon
deal
at a
with the
higher
proximal
pressure at
segment?
this time.
We have
But we'll
several
go in
options.
again
We could go with the
with a
cutting
3.0
balloon.
and we'll
We
pot
could
it
go with
further.
Nancy balloon, or we could go with the orbital. We have thick calcium there, 300 degrees of calcium. Now when you look at that OCT image, you see the thick entire plate of calcium at the ostium. And at this point, we know that just using a cutting balloon is not going to be enough. We aren't going to be able to fracture that calcium. So at this point, we've decided that we'll have to go in with the orbital again. But then orbiting at this point is a slightly difficult proposition. We've had to take in the microcatheter once again. We're changing for the wiper wire. There are two problems now. We have a stent distally, so we can't take the orbital distally. We have to keep it away from the stent. The second thing is that we are at the ostium. We can't take the risk of it jumping into the left main.
So this is a point which gets tricky.
Some
You
nitro,
have a
Nicoran, please.
stent distally. Let me see if I can
Dilators.
mute it. Yeah, I'm just trying to do that.
We have some.
I don't think I can do it from here.
I mean, have you assessed the left main? That
No, can
proximal
you tell me from the
LAD
free-
lesion, does it go back
Wire,
into
please.
left main? Is there significant disease in left main?
No, we didn't find significant disease in the left main, but the proximal LAD was diseased significantly.
Is there
So
landing zone?
we would have to do an osteal placement. And the problem here now was because of the stent distally, an orbital, if it comes into the stent, we are in a major trouble.
So Sarita, you chose the orbital atherectomy for the proximal.
We've taken the
Yes, but why you didn't
orbital
choose
in at this point,
IVL?
Okay.
pull it back a bit,
So in India,
and
the
then we are
patient
going to
pays for
just
everything.
orbit backwards.
And if you have an orbital on the table and you're opening
Let
another
me take a
IVL balloon,
shot here.
that's another 3.5 lakhs for the patient. One. Second, the beauty of orbital is that it can deal with all vessel sizes
Can you get the
between
wire?
less
Okay.
than 4. This was a 3.0 vessel at the proximal. So
can deal it with the orbital.
let's do another run of orbital here.
We had the imaging. Why didn't you do it in the first go? I mean, that, you know, we had, everything was clear even at, I mean, suppose the imaging didn't go ahead, the proximal part could have been imaged. And when you move the orbital through, because if everything, I mean, after doing orbital, you did an imaging, and the decision to do the whole vessel was done at that time. This calcium was known at that time, before stenting the distal vessel. What I'm saying is all manipulations in a freshly placed stent, longitudinal stent compression, losing the diagonal, they're all real. Now, the other part is that even without an imaging, anyone, you know, a mid-LAD 3, if you're going lesser than that, think twice. You know, 2.5, 2.75. For those who are not imaging, they are also looking at these numbers you get with a lot of imaging. And AI is going to be starting telling us these things. So when you're going lesser than a 3 in a mid-LAD for a pot, you have to have a very genuine reason for that.
Okay. So
Bring
two,
of
three
the
things.
orbital.
Why didn't we go ahead with
Slightly
that?
forward, and a little backward again.
Why didn't you orbital
Done.
the first
we
time?
Two, three
Let's-
things. One is that when we orbited, and we orbited the entire distal area, and then after, when we had imaged and we had orbited, at that point, this patient started having pain. And this patient's hemodynamics started deteriorating at that moment. We said, let's secure the distal lesion. We were going to orbit in the proximal lesion. Also at that time, we also had a thought, can we deal it with a cutting balloon in the proximal lesion? And then later, we re-looked at the calcium. So at that time, all we wanted to do was secure the distal area. Second, why, when I post-dilated with the 2.5, I wanted to upgrade the size for the proximal part of the segment, but we knew at that time that now I'm going to stent the entire area, and I'm going to go in with a 3O balloon, and I'm going to overlap. And that's the time that I'm going to use a 3O balloon and dilate that entire segment.
Yes,
So that's how we know that we're
with
going to do that.
very good teams and support in the lab, it's fine. But if you're working solo or with not too much support, you know, like a TAVI, most of our decisions do end up getting done before we go in. And so much doesn't change along the way, but we have plan A, plan B, plan C. And that's the beauty of this case where we are able to see that so much thought goes into the planning.
Yes, surely. So I think the strategy is changing as
If
we
everything's okay.
So the beauty of
Yes.
intervention is that
Okay.
what unfolds
Done.
in the OCT, what unfolds as you take the case along. The beauty of an interventionist is that they adapt to the scenario as the case unfolds. And also, me showing this is showing the benefit of orbital atherectomy. I just went ahead and I burred backwards. You can orbit backwards. Unlike rota, which only works in one
Yes.
direction, it's unidirectional, orbital is bidirectional.
I locked it. Let me
So
just check
I'm
it out.
actually orbiting back and forth in that region and not going anywhere
We've
near
got
the
the
stent. So that's the beauty of
microcatheter
orbital
in.
atherectomy. That's the beauty
We're
of this
changing for
technology.
a run through.
So if cost was not the issue, would you have taken an IVL?
So for me,
So
even if cost was
we've
not
exchanged
the
the
issue,
Viper wire
I
now
know
post
that the,
orbital for a run through
orbital
wire.
can deal with superficial and
And
deep calcium both. So I would normally take one therapy. And if you're not being able to, orbital works on two technologies, differential sanding and also the pulsatile. So the differential sanding will work on the superficial calcium. The pulsatile therapy will break the deep calcium. It will change the compliance of the vessel. So if you have one technology, we always try to cut cost in India. And the beauty of orbital is that it can deal with superficial and deep calcium both. So I would finish the case with a single technology. And we did use the orbital.
We've done
in
the orbit
proximal
cut.
segment. After that, we did the orbit cut.
Center,
we took in
please.
a cutting balloon.
Also look at the distal stent. See how that is.
And then we're taking
I think I'm good.
Time.
OCT once again.
We can hear the organizers call us for
Okay.
the time. and
Yes.
It's a short left main, so
Which is why I'm like,
there's always an issue.
not pausing it anymore.
Yeah, if you can show us the final result, I think.
I think we got a good one. Did you get the proximal also? Great.
So this was
Stent
the
looks
OCT
well
run
expanded.
after the stenting and after the orbit cut.
No
in the
dissection at the
proximal
distal
segment.
edge. There are
We got-
fractures which you can see.
We can see the
Yeah.
fractures, we can see all of it.
Let me take
And,
the OCT out.
Let me try
Sarita,
going.
Sarita, sorry, in a live case,
So I
you'd
think
have
at this
said,
point we have a well-expanded
Yes,
stent,
boss.
no edge dissections,
get
great
the
MSA,
can we get the
and a
audio
proximal
down?
segment
In a
where we
real
did.
live case, we would have just said, please complete, we will go to the other lab and come back. So in that.
Yes. So let me just go
So
ahead
let's
and go to
just
the final.
complete it. Yeah, show us the final. And the discussions is really what it is. We know, you know, your skills are immaculate and you do a wonderful job. So let's see how we concluded. And I think the questions we've raised and stirred the pot.
So we took
that's
a
what we
final
want.
OCT after the stenting in the proximal segment. We did the post-dilatation with a 3.5 and we did the overlapping area also, and this was our final result. In the interest of time, let me come to the final result.
So an applause from the audience.
Can I just make one final point? It is an excellent result, but we have to remember that sometimes perfection is the enemy of good. And what Dr. Mamas made a point, in future, if there is a restenosis or further atherosclerosis, we need to think of what the strategies open for us are. You won't be able to put in a lima to the distal LAD if you have already stented it, or use a bioabsorbable stent, or just do a DEB rather than stent the whole thing. So just a word of caution with experience from 1983. We are started from POVA, come back to DEBs now.
Yeah. So another comment, very important, a calcified lesion. You see the MLAs. You know, what looks opposed and fine is fine. Angiographically, I mean, at these 2 points, the proximal and just above the diagonal where we see a little under, if on the OCT we had a good MLA and a good apposition, leave it. You don't want perfs, you don't want problems. And talking of surgeons, see, I think as a cardiologist, I never realized it. I saw a couple of patients. These calcific vessels, the surgeons have a different suture needle. They have a cutting needle. Their anastomoses are terrible, and those grafts close. So in very calcified diffuse disease, we've always been primed to thinking, oh, surgery is final and lima is final. But the closures we see and the difficulties they have in anastomosing these calcified vessels is real. So we are fine in today's technology to do what we do. If it comes back, never mind, we'll do the DEB, or we'll protect, or we'll do. But diffuse disease, I think all of us ladies should put together and our experience and start publishing. We've really got solid stuff to tell the world about.
Perfect. And I think today intervention cardiology has progressed so much that if the patient comes back, all the people on this panel are going to make an amazing case of dealing with it once again. Thank you so much.
So heartiest congratulations, Dr. Sarita ma'am. It was indeed an amazing case. And as I invite now for the next live inbox case, Dr. Rupali Khanna, Professor of Cardiology at SGPGI Lucknow. And all over to you, Rupali, for rocking as ever. And by the time Rupali opens her case, you know, with the last case that we have, ischemia trial has shown that patients with chronic stable angina can do very well on medical therapy. So I do not know, but in real world practice, maybe this patient, if left on medical therapy and no angina or angina stabilized with optimized medical treatment, could have been an option which we can actually, you know, always be pondering about. So if Rupali is ready with her case.
Thank you, everyone, and I'm really privileged to present in front of such a eminent panelist. And as we were discussing, when the patient come back, what should we do? So my case is about that only. If the patient is coming back post-PCI, how to approach and how to give him the maximum result. So this is one, yeah.
So by the time Dr. Rupali is opening her case, I would like to have comments from our co-chair regarding what is their take on optimized medical treatment in patients. I know we have the best of interventionists sitting here, but still, you know, that is what the data unfolds, and for the benefit of audience, what's your take?
I'm not a very good interventional cardiologist if I can't hold a microphone, but there you go. I mean, I'm very strongly passionate about lipids. I mean, we do great jobs, but how many of us actually measure what the lipids are post-PCI? Certainly in my centre, you know, very few people do that. And we have very strong data now, particularly for high-risk lesions, so lesions with high lipid core burden, thin cap fibroatheromas, that groups of compounds like PCSK9 inhibitors can completely change the remodeling of these lesions and reduce future cardiovascular risk, as per the FURIA study, as per Huygens Yellow 3 study. So I think we have to pay much greater attention to lipids, but also to intravascular imaging, phenotypes of the disease that we find, and guide our lipid therapy appropriately. So I generally aim for an LDL cholesterol of less than 1.4 in these cases.
I was just going to say that the medical management exists, but now we had all of these technologies and we always feel like fixing everything. And right now we are kind of in the transition, and it doesn't come from us wanting to fix everything. I think the clinical cardiologists and the internists also want us to fix everything. But right now it's a learning experience. These patients that refuse to have, when you explain, oh, your disease is very complex, we need to use road ablation and special balloons, and there are risks, some of those patients say, no, just leave me alone. And we are learning from those patients that those patients do fine. Like in the follow-up, they do fine. So now we are learning in retrospective, like how do they do it.
Yeah, so your point's very well taken. Thank you. And I think Rupali is all set. Not set and not ready yet. Well, we had a lot of questions, you know. So would the entire panel go in for orbital arthrectomy, or maybe have a choice other than that? You know, would you like to go in direct? What's the take of panel for that?
But it depends on the availability. Most of centers are not equipped with orbital, so we are forced to choose between rota or lithotripsy.
We assume that everything is available. So assuming the availability of everything, what would be your choices?
Well, I think if it is, because most of us are forced to cut down on cost. Because in India, we have to do everything cost effective. So probably if it's available, I would have gone orbital.
So I wanted to do a comment about this case in particular. I'm from Colombia. I practice in Canada, but I'm from Colombia, and I understand there are countries that we cannot use a shockwave all the time. Like shockwave is expensive technology. So as Sarita was saying, I cannot open as orbital and then a shockwave. That's an expensive procedure. So we are, in Canada, we are using the OPN more and more, and we published last year a registry. We were afraid of perforation before, so we tried to understand how this balloon works, what is the threshold to do a perforation, and as Sarita said, we understood that you had to undersize the OPN. So actually the most used OPN is 2.5. So if I'm doing this case and I see that proximal LAD, I would have probably used a 2.5 OPN or a 3.0 OPN very safely. And actually the modification you get is similar to the shockwave. So now we are doing, there are 2 trials ongoing comparing IVL and OPN, trying to get our community to lose the fear we had about OPN, because OPN is a helpful technology that works if you use it carefully and use undersize always. I think we can, it's like a bailout for this.
Yeah, so tell me one thing, this is very fascinating. Would you stent and then OPN, or you would undersize and prep the vessel well with a 2.5, and what is left then do a second OPN to optimize?
That's a great point, because OPN also gives you those 2 opportunities, right? If you're afraid to do a lot of calcium disruption before, actually the OPN is the easiest technology to use post-stent as well, because the profile is very good. It goes into an underexpanded stent, and you could create fractures beyond the stent as well. So it's one of those technologies that you can use pre or post.
I would never, ever, ever stent a lesion that I don't think could be optimally dilated, because then you may have a situation where you have a stent with a suboptimal MSA that would risk stent thrombosis. So I don't think we should be stenting and then using OPN to achieve good expansion. You have to be confident that you can achieve good expansion before putting your stent. I've seen too many horrific cases before to do that.
Right. So I think the case is still lingering, even though Dr. Sarita is sitting, and we are having all the very nice post-case discussions. By the time, Dr. Rupali, they load your...
I
that's what I was about to.
we
Maybe you
have
can
that, ma'am.
introduce your
Can you
case.
skip that part. So this is, I will just talk about my case. He's a 57-year-old gentleman, and am I audible?
Please use the mic more.
Yeah, okay. So he's a 57-year-old gentleman, and he presented to us in 2022 with anterior MI at that 5 days post-MI, but he was having angina, and LED was having a proximal plus minus 100. Yeah, I think I got my slides. How can I change my slides? How can I change this? Okay, perfect. So this is our institute. It's a government sector institute. We're having 8 fellows. We are a team of 8 people in our institute, and we are proud to present the case in this symposium. And for the moderator, for the live, we kept Dr. Arun Mohanty, sir, from Gangaram. And this is our team. So can I just play this video? Can you give the volume, please? So I'm introducing my cath lab team. With me is Dr. Kapoor, Dr. Tiwari, with our the senior resident, Dr. Harshit, and our nursing staff. And OCT was Mr. Bhatti, and I was there. So
Actually, you can talk, Rupali. It's a blessing in disguise. We can have the case moving, even if the audio is not there. We can have,
can have the slides, please.
Yeah, you can talk.
Yeah. Can you just go to the next slide? I have just introduced my cath lab team. Can you just go to the next slide? So go back. So this is what I tell about 59-year-old gentleman, diabetic, anterior MI, post-PCI, we deployed a DES of 338, remained asymptomatic for 1.5 years. And if you see his blood chemistry, LDL was little higher, 72, but good HbA1c control of creatinine clearance. And this was his presenting ECG after like 1 month prior to come to us, having no fresh changes. There was old anterior MI changes with no LV dysfunction, new development. So if index procedure, if we see, this is the index procedure. At that time, when in 2022, when he came, it was a thrombotic occlusion of LAD, and RC and L6 was normal, and LV angiogram was showing a viable territory, and he was having post-MI angina. So we deployed a osteal placement of DES 3 into 38, and we confirmed in different views, and we were sure that we did a good stent expansion. And post-balloon, we did a proximal dilatation of 3.5 and 12 NC, and this was the final result which we achieved. We were happy. That was well expanded, no pinching, no shift of the L6 or the ramus, and we didn't do imaging at that during the index procedure, and it was angiographically looked a good result. Patient remained asymptomatic for 1.5 years, good HbA1c control, LDL was 72 on a high-dose statin, and we stopped his DAPT at 1 year and continued a single antiplatelet. But after 1.5 years, he came to us with anginal exertion, class 2 for 1 month. Obviously, we have to suspect that either an instant restenosis or a new lesion. We took him for angiogram, and this was the angiogram which we got. There was definitely a instant restenosis in the ostial and the proximal part of the LAD stent, and having a TB2 flow. So we don't know how the left main was there, and this was the osteoproximal LAD edge restenosis. So what next? Now it is open to the panel. So how will you approach this case?
The angle between the left main and the LED is a very tricky angle. So, usually we place it very well and we don't want the ramus, but they are in different planes. And optimization of, I think it was 3.5. And what imaging has taught us, we've undersized. So first is image, whether you have IVUS or OCT is fine, IVUS may be better, and image the vessel well and understand why the restenosis has happened. And on that, then make a decision of plaque modify, and most likely need to put another stent. You may be good with a good plaque modification and DV, but depends on what the imaging shows.
I was going to say that.
Yes, sorry. I think Natalia is there. OCT will definitely be better in this case. ISR, it gives you better definition. You get understanding of better pathology. And the still left main, you're still better off with an OCT. I think my choice would be an OCT, and Natalia else.
Yeah, I think I will use OCT. I prefer OCT for a stent failure because it gives so much details. But I was going to say in this case, in the acute setting, the operator had to do a quick PCI, right? They just put a stent. They felt it was placed in the osteo. Now you're going to show us the imaging. So probably there are some struts in the left main, trifurcation. And also it was undersized for a proximal LAD. So probably what happens, once the thrombus resolve, you get this left-acquired malapposition and then a non-optimal PCI. So probably we're going to see like a mixed mechanism of undersized stent with leg-acquired malapposition and new plaque like inside the stent. That's probably what we are going to see. And it's interesting when you do a non-optimal PCI in ACS, the patients have these events and they become symptomatic like after the first year when you stop the dual antiplatelet therapy because that's when everything starts happening.
So how long this was post-PCI, Rupa?
1.5 years.
1.5 years. And the patient was still on dual antiplatelets?
No, we stopped after single antiplatelet after 1 year, and there was no need for it. He is asymptomatic.
Right. Questions on optimal medical therapy and undersized stent, best of OMT is not going to work.
So I agree, these were the things we thought either we have underexpanded the stent or there is some geographical miss. We have not covered the ostia properly, or there is some struts which are hanging in left main. So these are the discussion which we wanted to from this case. And so OCT was the best.
Yes, on imaging, unless you're a very high volume centers, master 1. And when you're doing left mains, IVOS has some edges, master 1. Images look very good, but sometimes we just get confused.
Yes, I think he's on high dose statin. I would definitely have added STMAP for this patient.
Yeah.
In this case, do you
LDL
feel
is not acceptable. We can go lower down in a diabetic male. That is, as a interventionalist, we need to look at optimizing their risk factors as well.
Now it becomes a high-risk PCI because it's a high-risk re-intervention. So we need LDL according to ECC and EACC guidelines, at least less than 50. We cannot keep it at 70 now. So we will discuss the medical part. So now we come over to the image.
Yeah, one thing is, do you feel that physiological study in this case is useful?
You're not audible.
FFR, IFR, anything is it?
FFR and IFR.
No, sometimes symptom is subjective. So I feel the lesion, you think it's so significant that we have to go ahead straight away?
Actually, one was the patient was symptomatic and I was getting a TIMI2 flow. So whatever it is, that is the stenosis which had happened causing significant stenosis. So we didn't consider for FFR, IFR. But if it's a borderline lesion and having atypical symptoms, then totally physiology comes into play rather than going for imaging directly in this case. So we went ahead with OCT. We all know these are the risk factors. Either we have done some osteal, it's a diabetic, we put an osteal lesion, and stent or procedure related, either we have underexpanded the stent or a geographical lesion miss and smallest post PCI. So we strategy-wise right radial route, glide sheet of 6/7, EBU of 3.5, and to start with the intravascular imaging to assess the ISR mechanism. So before going, can you play?
Yeah. So we have just wired the LED and we are just doing a small balloon inflation because there was a TIMI2 flow in LED. So I was not very sure how much good image we can get with an OCT. So we have taken a 2.5 into 12 mm NC and just do a low pressure dilatation about 8 to 10 atmosphere.
To create a channel for the imaging catheter, is it?
Yeah, so that we can have good blood contrast, we can have clearance.
Dr. Tiwari, would you agree that, doing such cases...
Dr. Rupali, I think there is a channel, you can do a OCT first.
I agree, there is a different track, sir, but that was a TIMI2 flow. So I was little skeptical how much clearance of blood I can achieve in this case.
Is it possible to
so I just did a small low pressure balloon. Yeah.
Okay.
Now at least I get a good LED flow. So the clearance was...
Is it possible to have the video on and the voice muted? Would that be okay?
Yeah, I think it's let it play, and because we can have a discussion also. Yeah. Can you just run it?
It was a challenge.
So
OCT.
Okay.
We did an OCT.
That's fine. My choice of imaging in particularly ISR is definitely OCT because you get tissue pathology and tissue type, whether it's a NIH, neoarthrosclerosis, same time you get to know about your underexpansion like other mechanical issues. So OCT is an appropriate tool for ISR. It looks a very good run.
Yeah,
Dye clearance is very good.
Blood clearance. Yeah. Yeah, good.
Yeah.
And now
Yeah,
you
yeah.
can see
So
better.
we can see good clear coverage of the stent struts. There is no uncovered stent struts which they have seen. The
Yeah,
distal part is
absolutely
well
marvelous.
expanded.
Yeah, very good healing.
Very good healing. This is also fine. We are not finding any
Yeah.
significant new atherosclerosis or fibrosis in
Nothing.
the mid part
Nothing.
or the distal part of the stent struts. And this is the diagonal septal which just joined, and
Yeah.
still the stents, now the disease segment has started coming. So if you see that is having a
Yeah.
heterogeneous appearance, if I'm not wrong.
Yeah.
On no, there is new atherosclerosis. There is a heterogeneous appearance. If you can
Yeah, there
see
is a
that
microvessel you can see clearly. You can see microvessels
yes,
inside.
microvessel that's about 5 o'clock and there is new atherosclerosis. This at the proximal part, there is significant stenosis, which was the disease part, which we saw angiographically also. And the ostia, I think we have nailed it. Just come there.
Yeah, yeah.
We have nailed the ostia already. We are just, if you see the LCX coming out, only 1 or 2 struts just at the carina we are covering. So the ostia
Exactly.
part is good placement, but still it has developed restenosis. So we at that time we deployed a 3 mm stent, made it a 3.5. So we had a not an issue of a very under expanded stent
No,
strut.
I don't think there is an issue of under expansion in this stent. Yeah. So
So I think
mechanical is out.
Yeah, mechanical is out. It's more of a patient profile or what it is, because developing in new
yeah.
atherosclerosis, because it was a well deployed and well expanded stent strut with a good ostial nailing. So at least the mechanical
Yeah.
part we have to rule out. So what will be the approach, sir? Now we saw that the mechanical is ruled out and new atherosclerosis.
Yeah.
Should we go ahead with your DES or you need something else? Because we didn't find any much
is the patient
neocalcinosis.
diabetic?
Yeah, he's diabetic.
Is the patient diabetic?
Yeah, he is diabetic but good control.
Well controlled.
HbA1c was 6.7.
Because even the distal part looks pretty good, so that.
So it was sirolimus eluting stent, yeah, 338. Yes. So this is the OCT which we got, and if you can see what we have discussion of under expansion or missing the ostia or hanging into left main. So we didn't get that part. So this was the runs which was having a new atherosclerosis, having microvessels, and a good expansion part.
Seems
So
to be
now
really
what next?
aggressive atherosclerosis. Within a span of 1.5 years, he's developed so much. Because 22 you said, and within 1.5 years.
Yes.
So I think we really need to go very low on LDL in this patient. I would like to keep it really less than 30. Maybe add on inclisiran also, that will be a good option. And you can see in this OCT, you can also see some calcific proximally. So what is your take on it, Natalie?
Yeah, I was going to say that, but I don't think this stent was the size of the vessel. There are some runs that you see some calcium like by 6 to 9 o'clock. So the plaque was not modified before putting the stent. And then you see a type of tissue that is not the vessel wall. It was probably some organized thrombosis like around the stent. So I think this stent was undersized based on the vessel size. And also this type of neointima layer, as you're saying here, like this is, it happens in diabetic patients that around the struts, the attenuation is very low. It's like a layer. So you have like a low attenuation peristrut, and then you have the homogeneous neointima. So this is not such a benign pattern of neointima because there is a lot of inflammation peristrut. So it happens in patients with diabetes.
I mean, my concern is that in certain areas, the stent is grossly undersized, and you really need to know what stent was used, because obviously a 3.0 stent from different manufacturers will have different expansion capabilities, and I think that's going to be really important for you. I personally wouldn't be using another stent here. I mean, I think drug-coated balloon, absolutely. In terms of some of the fibrocalcific disease, I probably have a very low threshold for a cutting balloon, but then really aggressive expansion before using the drug-coated balloon at the end.
And the other thing is in this post-COVID era, most patients who are post-COVID, they come back with aggressive new atherosclerosis. So I think we need to look into their antibody titers and the history of post-COVID. Because I have been seeing patients who have come with the new atherosclerosis, and also they're coming with de novo aneurysmal or ectatic vessels with thrombosis. It is not just in the acute phase. Even after 2-3 years of COVID, they're coming back with lesions, especially young.
So what we assume that it may be that because the calcium, which Dr. Natalie also mentioned, we saw, but that was only one arc of calcium, which was not a very heavy neocalcinosis, which we found. And the EL to EL, which was able to get, it was hardly 3.25, 3.3. We didn't get a very big artery in the proximal part. In the EL, the calcium part, which you are telling about. So the under expansion part, undersize, we're not very clear. But yeah, definitely there was a layered neointimal hyperplasia, then there was atherosclerosis. So it has a multiple, because no instant can be a single morphology. Sometimes you are surprised with having a different morphology. So distally it was a more neointimal hyperplasia, proximally it came more lipidic plaque, new atherosclerosis with microvessels in this case. So it was, we are dealing with a more aggressive development of atherosclerosis in this case, rather because if it had been a stent related, the distal part and mid part was totally fine in this scenario.
Rupali, for the benefit of audience, we have several students in cardiology also sitting here. Would you let them know that how it is important to, like whether it's under expansion or whether we are dealing with neoatherosclerosis, and what could be our possible strategies and what strategy we planned for this patient?
So I agree. So this was the strategy. So we all know if it is a mechanical cause, we have to overexpand the stent, either use an OPNNC, or you have to high pressure balloons, or if there is a calcium which is there, you have to use an IVL in these cases sometimes, or you might have to some rotablation also, suppose there is a very calcified artery. But if you're getting a neoatherosclerosis or intimal hyperplasia, then maybe a simple cutting balloon followed by a DEB or DES will do. Then you don't have to aggressively prepare these lesions. So for in my case, we didn't find much calcification, so that we know that we don't have to over-prepare this case. Maybe a simple cutting balloon followed by a DEB or DES can be done. So we need a plaque modification. It's a type 2B instant restenosis. So lesion precision, but preparation is critical. So plaque modification, we thought we can go with a cutting balloon on an NC in this case. So we did a cutting balloon of...
going ahead with 310 cut-in balloon, and let's see how it behaves. We can take an OCT run post-NC then.
And post-cutting balloon, I'm just switching the, going fast. We try to do a 3.5.
I'm max going into 10 to 12.
But
no, you see it's slipping back.
Slipping, yes. So that's why, you know, I don't prefer going, yeah, okay.
So that is the importance of doing a cutting balloon, you see, realize.
Yeah, let me just go slow. It's slipping.
Yes.
So now we have to be very careful when this frequent slipping, because these are usually neointimal hyperplasia. This is known as watermelon effect, seeding effect, which we see that if you balloon slips very frequently in these cases, you're going for there is very increased risk of dissection. You might dissect the left main part. So you have to be very careful when doing these cases. So we thought, despite this repeated NC, we were not able to do it. So we came back to cutting balloon, and this time we went at a little higher pressure, so that at least we can get a good cuts in this case. So
done, sir.
3 into 18. 10.
Yeah.
We went up to 18 to 20 atmosphere in this case, and post.
So we can keep it for another maybe 20 seconds.
Yeah. What is the RBP of a Wolverine?
Good morning. See, RBP,
it is not good strategy. Those of us who've seen terrible complications with cutting balloons, it's not a great strategy to go to such high pressures. Melon seeding is known. You just have to be patient. You take an adequate length balloon and go up very slowly. Sometimes, you know, when you're not with your regular team and you're going too fast, that's when you melon seed. But Wolverine 18 atmosphere with a previous stent and your blades get stuck in that, or you can't deflate the balloon, it happens. People have had it happen. Why should we see it again?
So your artery was 3.5?
Two school of thoughts. I totally agree with Dr. Rupa, ma'am. In our institute, I missed that slide. We had a discussion also. While inflating the Wolverine, you have to be very careful. You have to go slow inflation, let the blades open, keep it for 10 to 12 atmosphere.
It's the melon seed also you have to protect.
Yeah,
At 18 atmosphere, I'd be very cautious. You've done it, it's fine, but I'd be very cautious. I won't be able to do it.
And this was little undersized. If you see, it was a 3.5 mm. There was one very good paper by Dr. Antonio Colombio when he used compare a high pressure cutting balloon compared to a low pressure cutting balloon, and he found a better MLA gain with not much risk of perforation. So I agree.
It's the same as an OPN, undersize, high pressure.
Yes.
But with a cutting balloon, it's a different, I mean, the whole animal is different.
Yes, your
These
point
are
is very well taken, ma'am. I mean, but at the same time, probably Dr. Rupali's mentioned that it was 3.5, so she probably felt comfortable. But yes, point well taken that for those who are not very regularly using, can be very cautious about the RBPs that we are getting with the Wolverines.
So regular or not regular, what is not recommended, please never
please
feel
be
too
cautious.
macho to be doing
Yes.
those things.
In fact, RBP should be respected for all the balloons and especially for
So
the Wolverines.
if I can just go back, I had a discussion also at that time that you have to be careful with 10 to 12 atmosphere. I agree with that part, but sometimes, you know, if you're undersized, you can go up to 18. So this was OCT, we took then OCT pullback, post-cutting modification.
Correct, so मैंने पीछे किया.
So there was some challenge in
Yeah.
taking
So the other
the
trick is like sometimes the OCT doesn't go, you just take the whole system in toto. You have to pull back the wire and then you have to do it.
Exactly. That is the way.
Yeah, sometimes it creates problem. Yeah, okay, I think we can start from here because the distal part we already documented
You are
that
through
it's
the
normal.
mid segment.
Yeah,
Yeah.
I'm through the mixed statement, sir.
ये
Let us check
बताइए।
the hooking. एक minute, let me check the hooking. Yeah, hooking is fine. Chal, you ready?
So definitely you have gained some area. It was 3 point something, it's 5.2 now.
It's much better. The plaque also, I think it looks significantly decreased.
Better.
Significantly decreased.
Yeah.
It seems to have modified significantly.
Yeah, can you go ahead? Go ahead. There are cuts. These are the
Can you
cuts.
document? Yeah, these are the cuts at 6 o'clock and you can see it clearly. And distal part, I think we didn't do much.
That's fine.
Yeah.
It's all.
So I think Ostia we have already did the plaque modification. We don't have to because maybe the NC is like slipping just like Tiwari sir also said that the Ostia. Sometimes just at the stent studs you might have slippage of 60.
So this was the post-cutting balloon OCT run. We could clearly demonstrate the cuts which have been done by the Wolverine. And we were able to do black modification. And if we see the measurements, these were the measurements which we got. So LED Ostia, we got about a 5.3, and mid-LED segment, we got about 4.3, and polygon of conference was
The
there.
ostium is quite clear of disease.
Yes.
Which means it's not extending to left main. The polygon is quite clear.
Yes, polygon was okay. So what next? Should we
Definitely
go for
overlap
a
with another stent.
DES or just like that? So what's the opinion
DES,
of the
it's an
panel?
edge stent, you have edge restenosis and ostium. You have to go for another DES.
The challenge in here is that that stent is super undersized, and then you have it failed for some multiple mechanisms already. So even if you get rid of the neointima, you get better expansion, it's just not the right size of a stent. So I know we don't want to put many stents, but I think in this case we will have to. We'll have like a big stent from the left main, and also these struts that we leave in the circumflex from an protruding LAD stent, those stent struts thrombose a lot, right? Like we see these cases, late presentations with some thrombosis in those ostial circumflex where this stent was left there without any treatment.
Yes, I'll just say that, you know, a lot of indigenous stents have not been studied. So the strut thickness, the way the drug was delivered, what happened, we just shy out and we don't discuss. Second, you've seen this. We also seen in last meeting we had at India Live, huge aneurysms forming in mid-distal LAD like a bunch of grapes. Now, none of us are talking and reporting. It's fine. That's the way technology evolves. But we should not be shy to not address this. And the next decision depends on what was the stent, how was the drug delivery, what happened. If it was I mean, you can't apply the results of A-lines, well-studied stents. That's an A-line stent to me. That two are the stents which are not properly studied. And so the radial strength, if that stent didn't have a radial strength, the structure wasn't good, no question, go in and stent. And now good edge to edge, there's no question of leaving it, whether you come back left main or not. That ramus is not going to bother you at all, it's in a different direction. But do a good job the second time.
I would not place the stent because that OCT finding looks okay. And within 1.5 years, this patient got instant restenosis, even though the LDL cholesterol was not really bad and diabetes was not so bad. So I don't want to place another stent inside of this lesion. Let's see, treat with the DEB and see what is going on.
So, I mean, it's grossly undersized, so I would be more aggressive in my post-dilation with a 4mm balloon. I mean, certainly, I mean, I've not measured it, but looking at some of your OCT, it does look like a 4mm size. I wouldn't be putting further stents. We have individual patient-level meta-analysis data from randomized controlled trials, the Daedalus study, in in-stent restenosis, and for second-generation drug-eluting stents, drug-coated balloons are non-inferior. So I would not be using a second stent here. I would be much more aggressive in my balloon sizing and would be using a drug-coated balloon.
So just maybe DEB is the... Oh. Sorry.
So DEB, was it what you used, Rupali?
No, I think this was an osteal, so because it was MLA, which we just got a 5.3 in this case. So I was not very keen of going to just leaving not DEB in this case. So it was, as we all know, that if it's putting a DEB versus DIS, it's always a confusion. So if it is a single first ISR, a single layer of stent starts, so as already said, if you compare with single stent, they both are equal. That have been not shown much superiority, but if it's a double layer, then multiple ISRs, then a DEB has a better role. So there was different meta-analysis also which have been shown that if you put everolimus eluting stents, in these cases, they have a little lower restenosis rate as compared to your DEB in these cases.
But what you don't show here, that's overall, but that's first and second generation drug-eluting stents. When you look at purely the second generation, there's no difference.
Yes, I agree. The RIPS for sure that it's not much, but in long term, the MACE might be a little more in these cases with this, which they showed. So I went with the earlier it was a sirolimus. I went to everolimus eluting stent in this case. 3.5 into 15 was deployed at the ostial part. And the best part is that there was already a stent start, which was mentioned there.
Yeah, we are getting hints.
I
for
think
time.
looks okay because the marker is just at the proximal end of the stent struts.
It gives a marker for this placement, and followed by we did a 3.5 mm NC.
What atmosphere is that?
Atmosphere.
So I'm going till, yeah, I'm just in Austria, I'm going to 16 or 18 atmosphere.
And post NC, we did an OCT pullback, which we found a well-expanded stent strut, good apposition. There was no significant malapposition. And it was covering till the ostia part of the stent. And if we see the measurements which at the ostia, which was earlier 5.3, we got a LAD ostia of 7.23 in this case. So better coverage and good stent expansion in this case. And this was the final result which we achieved, a TIMI-3 flow. There was no distal agitation. There was no pinching or carinal shift of the ramus. And if we see the OCT comparison, what we started with of LAD ostia of 3.2, which we are able to get and achieve good MSA of 7.23 in the long, assume that in the long run, if getting a good MSA, we will be able to, patient will be able to have a better outcome in this case. So this was the final result.
Show you the final picture.
And I'll skip it.
So heartiest congratulations, dear Dr. Rupali. I think it's been a great case and several learning sessions as to mechanisms of ISR and management. We are very hard-pressed by the organizers because we are already ahead of time. But I would request for one or two takeaway messages as we leave from the co-chair.
Be flexible, be nimble. Don't go take your egos into the lab. Always keep thinking and don't get hassled.
Well, the point is very well taken. Thank you so much for indeed a great session. And both of our operators have done a great job, Dr. Sarita Rao and Dr. Rupali. And we take off for the next session. Thank you very much.
I request Ma'am Seiko Takahashi ma'am to hand over the memento to Dr. Sarita Rao ma'am.
Sujata ma'am, if you permit, we can all have a picture and maybe collect our gifts down and save our time.
I request Dr. Mama sir to hand over the memento to Dr. Rupali Khanna ma'am. I request Dr. Shiba ma'am to hand over the mementos to Dr. Seiko Takahashi ma'am, Dr. Mama sir, Dr. Natalia Pinila Echeverry ma'am, Dr. PVVN Kumar sir, Dr. Rama Bala ma'am, Dr. Anupama Hedde ma'am, and thank you everyone for such a good live discussion, 2 cases. Proceeding to the next section, that is bifurcation lesions. I call upon the chairpersons for this session, Dr. Rama Chikkamuniswamy madam and Dr. Arundhati madam, and the other expert panel, Dr. Ipsita Mukherjee madam, Dr. Navjot Kaur, Dr. Neelam Kaur, Dr. Jayamala Mishra madam, to come onto the dais and chair the session. I now request Dr. Ritu Bhatia madam
Everyone, so we will be talking about tips and tricks for left main angioplasty. I think audiences, every one of you is doing left main. It would be more informative for the students. So 5% of the patients we do angio in have significant unprotected left main disease. Unprotected left main disease treated medically has a mortality, 3-year mortality of more than 50%. So quite a bit of mortality here. We know LMC supplies on average 75% of the LV mass in a balanced circulation. But if it is left dominant circulation, it supplies 100% of the left ventricle. So how important it becomes to correctly intervene in such cases. And you can see the average length is approximately 10 plus minus 5. The average diameter differs in all the cases, but average you can say like 4.9. And average branch angle also changes. It ranges from 40 to 165. We divide it in, anatomically, we divide it into 3 actually, ostium, midshaft, and distal. And the commonest reason being atherosclerosis, and the distal part is involved in maximum number of cases. Almost 2/3 of the cases have distal bifurcation involvement. Now, it's usually why the distal is affected is because we have branching there, and the low shear where the low shear force is, the lateral surface gets more affected, and the carina having more shear force is usually spared. It is, of course, diffuse, so it's unlikely that you will get just left main involvement. LAD is involved in more than 90% of the cases, and circ is involved in more than 60% of the cases. Commonest reason being atherosclerosis and so many other reasons, important to us being injury after left main intervention is one of the iatrogenic causes of LMCA stenosis. Indications of intervention, more than 50% angiographic stenosis, you have to intervene if there are symptoms or proof of myocardial ischemia. But if there is an ambiguity, IVUS-derived MLA less than 6 is an accepted cutoff, and FFR being less than 0.8. A little difference here, in Asian population, smaller subset, the cutoff of MLA has been 4.5 to 4.9. Now, in FFR, there is a little controversial thing. If you have a significant downstream disease, left LAD or LCX, you can have that affect your FFR, but in vivo studies have shown that unless the downstream stenosis is very, very significant, it does not impact really the FFR of left main. So you can go ahead with the cutoff of 0.8. Now, I just covered that. Now, what are the angiography view for most of the lesions? Osteal disease best seen in iliocranial and epicranial view. Shaft and distal left main is better seen in caudal views. You can see spider views or epicaudal views. For osteal and shaft disease, usually in LMCA, pick up a 7 French guide. From the radial approach also, you can have the glide sheet 6-7, but better is 7 French guide. Do not take very deep-seating catheters. Avoid Emplatzer and avoid the deep-seating catheters. JL works best in here. Coaxial alignment is important to avoid the injury, and keep the balloon inflation time short. So when you are inflating the balloon, you know you are you're giving a significant ischemia to the left ventricle. So try to keep the balloon inflation short. 30 seconds, you can have multiple inflations, 3, 4, 5, how many are required. You can have multiple inflations, but try to restrict to 30 seconds cutoff. We can actually have the contrast in inflation device diluted. If it is concentrated, it will take longer time to deflate. So try to keep it little diluted than normally you take. Try to keep it simple. When you place your stent across, pull the guide catheter back, have an osteal hang of 1 to 2 millimeter, and then go with the NC balloon and flare the ostium. We have a specific flash osteal balloon designed for that. You can use that, but it's not very easily available in our country, and we don't use it often. Modified Sabo technique is basically to give stability to your guide catheter. You wire the lesion, you place the other wire into aorta. It gives that stability to your guide, and you would usually not miss the ostium. Which lesion to stent first? We have usually LAD involvement, circ involvement, left main involvement. The dictum is address the downstream lesion first and then tackle left main. But if the patient is unstable or the lesion is unstable, you have a lot of thrombus in left main, you address the first and then go down. Use of hemodynamic support. We know if ejection fraction is low, you will definitely think of IABP or Impella. If the ejection fraction is in the range of 30s, IABP is all right. But if it is less than 20, do consider Impella very seriously. Other clinical pointers are if your systolic blood pressure is less than 110 to begin with, think of IABP. If there is a lot of thrombus in left main or if there is a lot of calcium in left main, definitely think of a hemodynamic support. Now, I'll just quickly take you through the classification. The lesion could be simple in left main or called complex. The definition is if the circumflex involvement is less than 70%, the stenosis is less than 70%, and the length is less than 10 millimeter, it is a simple case. You can easily go in with a provisional, But if it is other way round, if the length of the lesion is in circ is more than 10 millimeters, the stenosis is more than 70%, if there is significant, these minor criteria also you have to think, if the branch angle is narrow, less than 45, there is presence of thrombus, calcium, multiple lesions, and the main vessel diameter is less than 2.5, and the length of the lesion in there is more than 25, it becomes a complex left main angioplasty. So do think of upfront two-stent technique. So as I just said, you can actually follow this flow chart if the lesion is simple and if the side branch access is simple or easy. You can definitely go in with provisional or inverted provisional technique. Otherwise, you can think of upfront two-stent technique. Provisional, you all know that. Wire both, prepare the main branch, go through and through from left main to LAD, and then do a pot. Now, when to wire circumflex in a provisional stenting? If the angle, it's a difficult access for side branch, do think of putting a wire up front. If there is already a narrowing of circ ostium, do put a wire in there. If there is severe, a large plaque sitting in left main or LAD, you think there would be plaque shifting when you stent, better to secure the left circumflex first. And after putting the stent, if there is deterioration, of course you put the wire through. This is how it's done, simple, you all have done it. We call it provisional if it is from left main to LAD, and inverted provisional if it goes to the circumflex. Now SKS and V, not very much talked about, but very easy techniques. If the patient is unstable, very quick techniques. You know, if the patient is already in shock and you don't bother, it's a life-saving procedure, they are very good techniques, but of course you distort the carina here. In V, we just take the stents in, we prepare the beds as usual, we take the stents in V, the overlap is very much less, but in SKS, you take 4 to 5 millimeter of both the stents into left main. So the criteria is the left main has to be big enough to accommodate 2 stents, one, and the other limitation is, in case you end up dissecting the left main, the area left to you for putting another stent is so short that that size of stent is usually not available in the cath lab. So it becomes a little difficult, and in case you have to address the case again in future, getting in there is a little tough. Tap technique, a very good technique, easy technique, easier. In case you have done provisional stenting and your circ is compromised, I think we are left with only tap or culotte. So again, used in those cases, and you know how to do it. I mean, pot is important, and actually final kissing is also equally important. I'll not go into the detailed step. If anybody wants, we can definitely go to that. Culotte technique, the criteria is the angle has to be narrow, has to be like culotte. Both the branches have to be almost equal size, and the parent vessel, left main, has to be big. You know, then culotte makes sense. A lot of metal gets in the carina, so there are controversies, but considered to be quite good nowadays. We can actually, to reduce metal burden, we can have a mini culotte keeping lesser circ stent into the left main. Again, in culotte also, pot, repot is very important. So in every stage, you know, we have to pot both the stents and then the overlap part also. DK crush, considered to be the best for left main. We should all be familiar with most of the steps of DK crush. You actually do pot thrice in there. You do it in the first stage, when you crush the circ stent, then you do pot to the main vessel stent, and then you end up doing a final pot also. So there are lots of steps involved, but the advantage is it can be done with the 6 French system easily, and the outcomes are very good. If you do a good DK crush, the patient's outcome are definitely going to be better. Mini crush, quite operator friendly, I would say, but needs 7 French catheter, and you need a final kiss definitely here. Step crush, more like mini crush, but you can do it with 6 French system. Cone crash, you just make a cone at side branch ostium so that access is easier. There are few wiring techniques. I would not go into details, but few lines here. When you jail the wire, try to jail a workhorse wire. When you are skeptical about the access, wire the more difficult lesion first or the vessel first. There are 4 basic curves you can give to your wire before you start rewiring the circumflex through a crushed stent. And then there are anti-grade wiring, pull-back wiring technique, reverse wiring technique, where you make a fish hook or a safety pin kind of a loop, engage it at the circostium, give a counterclockwise rotation, it usually enters circumflex. So that is one technique. You have deflectable microcatheters like Venture, Supercross, they can definitely help in bad angles. Then you have a balloon block support technique. You take 1:1 balloon just beyond carina into the main vessel. That balloon, you keep it inflated at 10 atmosphere, that will actually help access the circumflex in a better way. Removal of jailed wire, be cautious, be slow. If trapped, use a balloon or microcatheter. In preventive mode, it makes sense to not leave too much of a wire into the side branch. Pull it a little, when you're crushing the stent, keep very short segment into the side branch. A final kissing balloon inflation is very important for 2-stent strategy. Pot is important, you know, to basically have adequate stent apposition to help avoid abluminal rewiring and facilitate rewiring. IVUS is definitely a plus. When you have a trifurcation, treat it like bifurcation, leave the smaller one aside, just try to keep it patent while stenting. You know about this 5, 6, 7, 8 law of MSA on IVUS. OCT gives you a better view in bifurcation, but ostial and very large left main, not a very good choice. So 80% of the cases can be done with provisional stenting. Have a heart team to discuss it. You can definitely have a very good result. Thank you. Did I exceed? Okay. Thank you.
Thank you, ma'am.
Questions later. So do we have any questions? Yeah, please.
That was a wonderful presentation. I have a couple of questions for you. In case you're doing a re-intervention for an ostial left main previously stented, what would be your strategy?
So the question, Dr. Veena, is if it is already stented.
And the patient requires a re-intervention.
Yes.
Because you're
So
protruding the stent.
Yeah.
So what would be a strategy?
I would still choose a short tip JL. I would try to be as coaxial as possible. And most of the ostial left main I address from a iliocranial view. And I will definitely, because it's already stented, I will have imaging on board. I will wire both the branches and have a IVUS run so that I know that I have not gone abluminally. And I'll address it like any other. But I will, of course, because it's ostial, I will use a cutting balloon also. So these are the different things which I would want.
Your pot of left main, would you use a semi-compliant or a non-compliant on a general
basis?
basis?
For pot, I usually choose a non-compliant balloon, but there are studies where semi-compliant balloon does a good job, but I would use dedicated pot. We have a pot balloon available now which has a very short shoulder, so I prefer using that. It has all the sizes also.
And when you're looking at Zabo versus flower petal stenting, Zabo, as we know, when you're wiring it to the circ, it may change your orientation
Dr. Veena,
of wiring.
could you go back? What did you say?
When you're talking about Zabo technique of...
Zabo technique, yes.
For placement and of accurate positioning, in case you're doing ostial LED stenting, because we know ostial LED disease is associated with left main distal disease in about 30% cases.
Yes.
So in that situation, would we be more comfortable with a flower petal stenting versus Zabo technique?
So I understood the question, Veena, is that Zabo technique, where do I use it, is one.
Yeah. Do you routinely use it? Or?
I do it quite often, Dr. Veena. Actually, when, besides giving stability to your guide catheter, Zabo technique actually, many times your, the movement of the stent is so much when you are, if heart rate is high, or if, even with the 70 heart rate, I have seen so much of movement of the stent. Zabo technique kind of stabilizes your guide catheter. And your system overall doesn't move much. So for osteal, I use it very often, and I do use it even for osteal LAD at times when my guide and the system is just not in a stable position.
Just a gentle reminder, all of you. Excuse me. We are running more than half an hour late. We request you to just keep that in mind. Thank you.
Thank you. Thank you.
Next speaker can come here.
I request Dr. Veenu John, Madam, Consultant Interventional Cardiologist, Apollo Hospitals, Mysore, to deliver a talk on circumference, the Achilles heel of the left main PCI. Just a small reminder, the talk will be of 10 minutes and the next 2 minutes will be for discussion. So just
Dr. Sujata, thanks a lot for organizing this conference so nicely, and also thanks for inviting us to be a part of it. Okay.
Good morning, everyone. So today I have this topic of circumflex, the Achilles heel of left main PCI. So we've been listening to left main PCI since morning, and some of the slides may be a repetition, so I'll go through it faster. So basically the outline of today's talk, what I'm going to give is why LCX is the Achilles heel, how to go about the LCX, and what parameters. No, back. Okay, yeah. How to go about the LCX and what parameters really matters. So we all know that percutaneous coronary interventions for coronary bifurcation lesion is associated with higher rates of in-stent restenosis, myocardial infarction, and revascularization as compared to non-bifurcation lesion. This we are very clear about. So the increased percentage of suboptimal results after stenting bifurcation lesions we have already seen in our live cases today is not always due to the extreme complexity of the lesion. So we had this slide already. I'll just run through it quickly. So what is complex? So the side branch diameter stenosis greater than 70% with the LCX lesion greater than 10 mm, then we know it is a true LM bifurcation lesion. With any of the 2-6 minor criteria, then we know that it is a complex lesion. So bifurcation angle greater than 70 degrees or less than 45 degrees, presence of thrombus, moderate to severe calcification, and the main branch diameter which is less than 2.5 or main branch lesion length more than 25, and presence of multiple lesions. So there was a study of 3D analysis of cardiac motion during the cardiac cycle and the coronary velocities. When they had done the study, they found that left circumflex had higher velocities than the LM ostium during the entire cardiac cycle. So when we see the peak velocity of LCX in systole, it is 56 versus 34 in the LM ostium with a significant p-value. Similar changes are seen during rapid filling phase of early diastole as well as during the atrial contraction. So this further emphasizes the point that the shear stress at the LCX ostium is much, much more and different from what is there at the LM ostium. Chavez et al. Had done a study of 563 patients. So what they found is LCX ISR treatment versus non-LCX ISR treatment, that is whether it is LAD or RCA. At 1 year, the MACE rates were much higher in an LCX ISR when compared to that of the non-LCX ISR. So what we need to recognize is these mechanisms that can lead to compromised flow in the osteal LCX. One is the plaque shift, wherein the plaque burden of the side branch increases, or it may be a carinal shift itself, which compromises the lumen of the LCX, or ellipse deformation of the
ostial side branch. So this ellipse deformation is very well studied in some of the OCT studies, wherein they find that the ostium of the LCX after the main branch stenting becomes elliptical. So we know very clearly that the FFR post-stenting doesn't correlate with the OCT diameter that we get. So if we use the elliptical area dimension and correlate it with the post-MV stenting FFR, it actually correlates better is what the study revealed. So apart from these, there can be dissection and protrusion of the stent branches. So what are the predictors of compromised coronary flow in the LCX side branch after LM to LAD crossover? One is the LM artery stent length. What is the stent length we use? LCX burden. So I'll be coming to few studies which have shown this. Plaque burden in the LCX. Then ostial LCX MLA on IVUS pre-stenting. And the bifurcation angle itself is actually an independent predictor of side branch compromise. So just to show a few cases, this is a 43-year-old smoker with 1 hour of angina. Sorry. 46-year-old smoker with 1 hour of angina with ST depression in all leads. His ejection fraction was 30%. So the initial shot will make a heart beat skip. So immediately we have wired the lesion and we did multiple runs of thrombus aspiration. We didn't waste time in wiring the LCX at that point of time because we just wanted to establish flow into the left coronary system. So after that, we can see that there is probably a plaque rupture. We didn't have imaging at this point of time. This is a 7-year-old angiogram. So we see that there is a lesion in the plaque as well as the ostial LAD, but the ostial circ seems okay. So this is the image after we have stented from LM to LAD, and we see that the circ ostium seems fine and it seems to be flowing fine. There is no doubt in this case. So next case is a 78-year-old man who's a diabetic hypertensive and has chronic kidney disease. He went with an anterior wall MI elsewhere where he was thrombolized and sent here for basically a rescue PCI. So this is how in the middle of the night at 12 o'clock we see an angio, and we are quite confused because it's a trifurcation of the LM. So all that we had in mind was to establish flow into the LAD. So we know that the LCX is small and diffusely diseased, but this would be in a clear-cut situation, reason for bifurcation stenting or probably a bypass surgery. So this is successful in establishing good flow into the LAD, and also the LCX is still preserved, flowing the same way. Case 3 is actually an 84-year-old gentleman who came with acute coronary syndrome and unstable angina, hypertensive, and ejection fraction of 50%. So we can clearly see that he has LM distal disease with ostial LAD stenosed. There is also lesion in the LCX. We can see that the angle is not very wide initially at the point where it's arising. So here we went ahead with the stenting of LM to LAD, and we can see how much the LCX ostium is pinched. So we did FFR of this circ ostium. So this is the FFR. Both the RFR as well as the FFR is non-significant. So there is no correlation between a post-stenting OCT or IVUS image, MLA, with that of the FFR, the functional compromise that we see. So we can actually see OCT images also after LM to LAD stenting, wherein we can clearly make out how the opening of the LCX is. So coming to management of left main lesions, this has already been discussed by Dr. Ritu. Just to run through, in an unprotected left main, significant on angiography, FFR being less than 0.8, IVUS minimum luminal area of less than 6. We think of either whether they are a candidate for CABG if the syntax score is greater than 32, or have a heart team discussion and go for a left main PCI. If it is distal bifurcation being involved, we need to decide whether it is a true bifurcation, wherein the patient has to go for a DK crush, or whether it is a provisional stenting strategy. So with us knowing LCX always giving the trouble, we should maximum think of a provisional stenting strategy, and later on, only if it is necessary, go for a 2-stent strategy. So here in this picture, we can see that the cumulative event rate is much higher right from the beginning once the side branch stenting is done versus if the provisional stenting is done. This was a study just to see by Lee et al. To show that even in a crossover stenting, whether we do the side branch opening with a balloon or kissing, or just do plain stenting, it really doesn't matter. There's not much of a significant difference in the event rate. So post LM bifurcation crossover stenting, they had tested the geometrical difference and the functional change. What is important in this is the pre-procedural MLA of less than 3.7 correlated well with the post-procedural FFR of less than 0.8. And similarly, a plaque burden greater than 56% correlated with the FFR less than 0.8. So the pre-procedural MLA didn't really matter. And according to this study, very clearly we can see that the angiographic stenosis was more than 50% was seen in 54%, but it translated into a FFR less than 0.8 in only 7%. So study by Wong, Zhang also, looking at single versus 2-stent technique.
I think you have to go to your conclusion slide.
Yeah, ma'am, going for it. So long-term results were clearly better in single stent strategy. So similar to the 5-year aspect also. So in whatever we say, so single stent crossover is much better. This one point I just wanted to show that there is this eyebrow sign which can be seen in either the IVUS or the IVUS longitudinal section, wherein the spiky pattern at the level of the ostial LCX can suggest that there can be compromise of LCX. So to conclude, LCX pre-stenting MLA, which is less than 3.7, we need to consider that there can be a compromise. LCX plaque burden greater than 56% pre-stenting, we need to be clear. Elliptical area calculation may correlate better with the post-procedure FFR. Shear stress is always high, which we have seen anatomically at the LCX, and hence higher event rate. And provisional stenting would be the best, and 2-stent if it's a true bifurcation. Thank you so much.
That was a good talk. I wanted to ask, you have any follow-up angios of these patients?
Follow-up angios are not there. The first 2 patients are actually 7-year-old angios, and both of them have not come for a re-procedure and are on regular follow-up. The last patient is only 6 months old, so we need to wait and see, and he's 84-year-old.
No, not that one. The first one you showed, no? There was a pinching
LM totally
LM to a
occluded.
lady,
That
then there
is
was pinching of circ. That patient.
That is the last patient.
Not the last patient, second, I think.
Second was
50% LCX. You showed FFR did not show
FFR
any.
negative.
Yeah.
That patient is only 6 months old, so we need to wait and see.
Fine. Thank you.
Unless they are. No, that is what. It's better to wait for symptoms, because most of the times the FFR and if the FFR is significant, we are either way going to do something about it. If the FFR is non-significant, then we just have to wait and watch for the symptoms, because most of them do well after it, and MACE rates are also much lower. Most of the studies have shown that. Yes, ma'am.
In the last case, you showed the
ostial of the LCX got pinched and the FFR was 0.9. But that ostial pinched to around, must have been around 95 degrees stenosis already shown. So how reliably can you just leave that lesion and make up a follow-up? Like, I believe you could have stented at the same time after doing all the plasty. I think it would have been more beneficial, because then again the patient would have again come up with LCX, stenosis, LCX MI leading to LCX stenosis. Since it's so obvious seen FFR 0.9, well, how reliably can we say it's very safe and we will not do any further? So what are your points on this?
That's what, ma'am. According to most studies, putting another stent in the LCX has much more higher event rate than having a single stent. So that is clear. Then the second point is,
Dr.
unless
Bino, if
the
you can...
FFR is less than 0.8, the MACE rates are not higher at all with respect to most of the studies.
Yes,
So it is better to be left alone than do something
I
there.
think I second with you. I think only 3 places when we have to go for a second stent here is, one is the FFR which you have proved, second if there is a visible dissection, and third is if the TIMI flow is less than 3. Otherwise we can leave it, and most of the studies have shown that the MACE rates are lesser even if the angiographically the lesion looks significant. That's why we have this technology.
If you can excuse me for a minute, we'll continue with the next topic. Any more questions can be taken after the debate.
Thank you so much.
I now invite Dr. Shiva Tata Chabra ma'am and Dr. Priya Palimkar ma'am for the debate. The talk will be for 8 minutes and 2 minutes for the rebuttal.
A very good morning to all of you. Thank you, Dr. Sujata ma'am, for having us out here into the city of destiny. And Dr. Priya, my dear rebuttal, I think the chair is already on my side. They've voted enough for provisional. Well, of course, Priya and me are very dear friends, but I have been given this job. I think the slide control is with... can I have the slides, please? I need to know how to run the slides from... Yeah, I am the first speaker, ma'am. I'm Dr. Yeah, so I've been given... Okay. Okay, so I'm going to present first, and then I'm going to be silent, and then Priya is going to come, and then we are going to... Okay, done, ma'am. Thank you. Thank you. So can I have the slides, please? So this is how I label it as, when the provider gives the provision of the provisional. Well, we have seen it enough. We know that the lesions are significant when it's Medina 111. We have also seen that we have definition criteria, which tells us that, a lesion more than 10, 70% stenosis in the circumflex tells us that we might have to stent it, especially when there's immense calcification, the bifurcation angle is less than 15, when there are multiple lesions, or the main vessel lesions more than 25. We've already seen that, and we have also seen that if we look at the purpose of provisional stenting, and once we decide to go for it, we always have an option that we can, go and secure the side branch. So the provisional stenting has stood the test of time across the several trials that we have had. This is the entire list of the trial mentioned, whether it was Nordic, whether it was BBC, whether it was Cactus, whether it was, DK Crush. The initial stages of all these trials did tell us that there was no significant difference as regards the MACE events was concerned between the provisional and between the double stent strategy. So these are the results of EBC main 1 year results, and they tell us that all across the spectrum, whether it was death, MI, revascularization, we had the MACE rates which were in favor of provisional stenting. And this was the comparison between the recent definition criteria which came. So we know that bifurcation lesions, they can be simple or they can be complex. And the complex bifurcation lesions have been supported by the use of double stent strategy, which was there across this DK Crush 5 which has come. So this did have a favorable results of MACE with a double stent strategy in DK Crush 5, which is the recent trial and can be in comparison to EBC.
But all said and done, we've had these results when we were using two-stent strategy, and the era of physiology and the era of imaging has now come. And we know that we can use IVUS, and a utilization of IVUS or physiology can tell us to look at the side branch. If we have an FFR which is less than 0.8, or if we have a non-hypervolumic pressure ratio which is less than 0.89, this tells us that we can very well leave this vessel, and this is across supported by the trials. So this is the list of trials which are there for the utility of FFR. We can see it. This is in the patients with provisional stenting, angiographic versus FFR guided. FFR guided was supported. The MACE rates were almost equivalent, and so were the benefits. And if we look at even in the patients with true bifurcation lesions, even in patients with true bifurcation lesions, the utilization of FFR to secure the side branch gave us less MACE rates. And if we look at patients with left main with jailed circumflex, even when FFR was done in them, the trials gave us that the MACE rates were equivalent when FFR was supporting. We know that angiographic results might not really match the results of FFR physiology or what we get with imaging. And my dear friends, we are all moving. These are the novel techniques that we have, the latest novel techniques which can be utilized even before going to the cath lab, can be a CT-guided FFR and virtual stenting. Virtual double stenting and virtual single stenting, when done in patients with bifurcation lesions, can tell us whether this patient or how this patient is going to behave. So if we have a complex lesion which gives us a CT FFR which is lower on a virtual stenting, we can go with the double stent strategy, else with a provisional stent strategy. So the technology is evolving, and we have been talking about drug-coated balloons. As we move further, we have got several trials with the use of drug-coated balloons after having used a cutting, and of course followed by a pot. And this is the list of trials that we are looking for drug-coated balloons in patients with bifurcation stentings. We don't have to put 2 stents every time. And Dr. Sujata had given me time of 5 to 6 minutes. I think I am done, but before I leave, after having shown all the data for stents, for DCBs, for virtual stenting, in an intellectual debate, both sides tend to be correct in what they affirm and wrong in what they deny. So having said that, I always believe that when God gives vision, he always provides the provision. And it's Almighty who is giving us the provision of the provisional, ladies and gentlemen. Thank you very much. All over to Dr. Priya for her talk.
If someone can help with the connection. Okay. Do you have my slides? Yeah, can you play from there? A very good morning to all of you. And at the outset, I would like to thank the organizers of WinCars and WCC for having me as a part of this debate. And thank